Hello.
And so orthopedics has always been a male dominated branch. When I joined orthopedics in 1990, orthopedics was equivalent to big biceps, very rude, arrogant, bit aggressive. Everybody used to be very afraid of orthopedic residents. In fact, most of the student nurses used to run away from orthopedic residents for obvious reasons. My batchmate, my close friend, she was my schoolmate, Dr. Sharmila Tulpule, Sharmila Kolarkar. She decided to choose orthopedic. She decided to be the trend changer in 1990 along with me. and she decided to take orthopedics. In fact, she would also recollect so many incidences in GMC where many patients used to call her sister, doctor ne bolwa, and she used to scream hard at them and fight with them ki me say orthopedic surgeon. The patients never used to accept that she is an orthopedic surgeon. So that is how that was the trend. Probably before her, we had only heard of one legendary founder of Children Orthopedic Hospital, Haji Ali, who was the lady orthopedic surgeon in Maharashtra. She was the first in Vidarbha. And it is really very heartening to see so many women, girls, they are opting for orthopedics. It is really very heartening. Neha told me that there are more than 400 women who are practicing orthopedics. They are not only practicing, they are doing exceptionally good work in their chosen field, and they are giving very tough competition to their male counterparts. I, on behalf of Vidarbha Orthopedic Society, welcome all of you. They are going to enlighten us on newer insights in orthopedics. So I hand over the mic to Neha for the further proceedings. Thank you so much.
Thank you, sir, for those kind words. So today we'll be starting our first session. So the chairpersons for our first session are Dr. Shushruth Babulkar, an eminent orthopedic surgeon from Nagpur, and Dr. Manoj Pahukar, another eminent surgeon from Nagpur. So please. Okay.
Good morning, everyone. So let's start with the first talk without wasting any time. And the first speaker, of course, is Dr. Neha Godghate, who is going to enlighten us on current concepts in rotator cuff tear. Or yours, Neha.
Yeah. Thank you, sir. So I'm Dr. Neha Godghate, working at Grace Orthocare Hospital, Nagpur. And today I'll be speaking on current concepts in rotator cuff tear management. So as we all are aware, rotator cuff disease is a common cause of pain and disability in elderly. So many of our OPD patients, in elderly patients who come with the shoulder problem, they have some of the rotator cuff diseases. Like if they have like tendinitis, they have either partial or full thickness cuff tears, or then last stage is cuff arthropathy. So as far as partial thickness tears are concerned, there have been many studies where they have shown the incidence is right from 13 to 32% in cadaveric studies. However, the natural history is difficult to predict. And in spite of so many studies, there have always been a controversial treatment protocol. So in 2022, there are many partial thickness tears which are getting diagnosed because of heightened awareness amongst orthopedic surgeons, and also because of high quality MRIs which are coming up. So does a conservative treatment have a role in partial thickness tears? So, well, yes, because Vital et al. In his paper showed that the arthroscopic procedure performed is less often in states that are densely populated, and there is no relation to the density of orthopedic surgeons. So this was one case. She's a young female who presented to me with 5 days history of trauma with left shoulder pain. She had inability to move the shoulder after a particular abduction. So her supraspinatus was grade 4, and which was painful. Infraspinatus was grade 5. Her MRI showed that there was an articular sided partial thickness tear. We gave her conservative management and she improved over a period of time within 6 weeks. Now it's been like 5 years and she is completely fine. I just called her up yesterday. She's saying I'm doing all my daily activities and I'm lifting heavy weights. So if the conservative treatment fails, definitely we can consider a surgical option. So this is the treatment algorithm. In cases of partial thickness tear, the physiotherapy should be given minimum to 6 weeks. If there is improvement, then we can continue the physiotherapy. If the pain and disability is persistent, then we can think of surgical line of management. So there are two schools of thoughts in surgical line of management: only arthroscopic debridement or subacromial decompression, or arthroscopic decompression with repair. So the first school of thought, only arthroscopic debridement, is not good because there is no evidence of healing on second arthroscopy. And in second school of thought, the decompression along with repair, they have shown that the strain levels in the muscle is near normal after the repair. So here we can see this is partial thickness tear on a bursal side. So after thorough subacromial decompression, the partial thickness tear is converted into a full thickness tear like this, and then a routine full thickness tear suturing is done. So now coming to full thickness tears, the surgical indications. In acute scenario, it is a straightforward indication for a surgery. If the tear is caused by fall or glenohumeral dislocation, then prompt repair is advised. In cases of chronic scenario, in elderly patients where your conservative line of management like physiotherapy, activity modification or NSAIDs have failed, then definitely there is a role for full thickness tear repair. But however, in chronic scenario, in a younger patient, the tear should be managed immediately with a surgery. So historically, the gold standard was mini open or open repair of the rotator cuff tear, but now the paradigm is shifting to arthroscopic repair because it is minimally invasive. Even a glenohumeral joint can be visualized arthroscopically, and the rehabilitation is faster. So there are two ways to repair the full thickness tear. One is single row repair. The second one is double row repair. There are many reports which are supporting double row repair. Lafosse et al. Showed that there is a constant score which is improved after double row repair. Sugaya in his cohort study showed that UCLA and ASES scores also improved, significantly improved. This is a recent meta-analysis and systematic review done in 2022. They have studied 15 RCTs, and they have shown that there is no difference in function or pain in single row versus double row. However, in cases of double row, the re-tear rate was less and healing was faster. Healing was better. So here are few more studies for single row versus double row, in which Park et al. Showed that the patients with initial tear more than 3 centimeter, all outcomes were better in double row. So if there is a very small tear, it can be managed with single row, but overall consensus is double row repair. Biological augmentation of cuff repair is nowadays, it is done very frequently. Sharmila ma'am will definitely give us insights about it. There are many injections which are injected after the repair, like BMP or PRP. And biceps tendon transfer in massive rotator cuffs, it is again coming up, where it is a biological autograft. So the goals of surgical management of massive tear are to achieve anatomic tension-free repair and to restore the force couple mechanism of the rotator cuff. So the options for massive rotator cuff repair are like latissimus dorsi transfer, then lower trapezius transfer, suprascapular reconstruction, and supracapsular reconstruction, and arthroscopic partial repair. So Lapner et al. In his 2022 study, they have showed that LDT is comparable to partial repair as well as LTT and LCR for the treatment of massive cuff tears. So there are many papers who have studied massive cuff repairs, and they have Burkhardt et al. Showed that all the patients with fatty degeneration of 50 to 75% will do good. They'll have a good results. However, the patients having more fatty degeneration, like more than 75%, the repairs, the results will be slightly compromised. So this is a new kid on the block, subacromial balloon spacer. It has been tried recently, and in cases of irreparable massive cuffs, they repair it partial arthroscopically, and this biodegradable balloon is injected in the subacromial space, and then a normal saline is injected in that balloon. So this balloon acts like artificial subacromial bursa. So it helps in healing, and it keeps the humeral head reduced. If there is a massive rotator cuff tear, the antagonist effect of rotator cuff is lost, so the deltoid pulls the humeral head superiorly, and gradually, as the humeral head is shifted superiorly, there is acetabilization of acromion. So for cuff arthropathy patients, the reverse shoulder arthroplasty remains the gold standard. So this is algorithm for cuff arthropathy. This was a case of again pain in the right shoulder for 3 weeks. She had fall. This patient had fall, and she had not slept in 3 weeks at night because of the pain in the shoulder. Her MRI was done, which was showing full thickness supraspinatus tear. She was repaired arthroscopically, and this is her 4 months follow-up. She has got full range of motion, and there is no pain. She was so happy that I could sleep normally now. So the take-home message is, in cases of partial thickness tears, proper trial of conservative management is done. If it fails, then arthroscopic repair and decompression should be considered. In cases of full thickness tear, acute scenario, it should be repaired. In a chronic scenario, in young patients, it has to be treated surgically. And in massive tears, there are multiple options. And in cuff arthropathy, reverse shoulder replacement is the gold standard. So thank you.
Neha, question to you is,
Yeah.
So basic question, when do you say it has, or the patient has failed conservative? Is it the decreased strength? Is it the continued pain and the timeline?
Yes. So first thing is, I would say that the pain and night pain and disability, if it continues in spite of proper physiotherapy, then it is a failed conservative management. At the end of 6 weeks, I would say that if the patient is even partially better than the first day of presentation, I would continue the physiotherapy till 3 months. After 3 months, if the patient is not at all happy or not at all relieved, then I would consider surgical management.
So do you not fear in these 3 months that you are converting that partial to a complete or a massive tear? How do you regulate that?
Even if it gets converted to full thickness, the patient will be easily convinced that he needs operation. Because we counsel the patients that these kind of tears are borderline for surgery. So if we feel that the pain and disability increases, then we'll immediately go for surgery.
What I was coming to you is, would you do a weekly ultrasound, which is a cheaper investigation, and muscle strength estimation, or would you just based on your clinical criteria continue?
I would do judging the patient clinically. I would not do regular ultrasound, because ultrasound is all the radiologists.
No, you have to do it. That's what I'm coming to.
Okay.
You do the ultrasound, so you know the measurements, you know the location, because you are doing it on the same patient yourself.
Okay.
That's what I was coming to.
Okay. I'm not trained in ultrasound, so I would go clinically.
Sure. Yeah.
That's a wonderful point that
Yes.
Shishwa sir has pointed out. It's a cheaper and very easily, readily available investigation which could be followed up.
Right.
My question is like, intraoperatively, how do you assess that this kind of either acute or chronic tear which has retracted much, you will need certain more augmentation, or you feel that this patient will not have a good result. So what are your intraoperative these findings where you think that you need something more?
So basically, I would say that it is a preoperative judgment. If the tear is retracted beyond glenoid on MRI, and it is very chronic, then I would keep the augments ready, But intraoperatively, if we go inside and after subacromial decompression, we see with the grasper whether the tear is coming in the place. If it is coming in the place, then we have to repair it like that. And even after complete release and proper subacromial decompression, if it is not coming at where it is required, then we have to use the augments.
The preoperative MRI will determine the
Yes,
whether the
yes.
muscles, how are the condition of muscles, and
Yes.
how much release you can go inside.
Yes. And even the fatty degeneration.
Fatty degeneration, yeah.
Yes.
And even now the newer concept is that the blood supply for the rotator cuff is towards coming from the bursa. That's why
Yes.
trying to preserve more of a
Preserve.
bursa, at least from the posterior aspect that you have pointed out correctly.
Yes.
So any more questions?
So if it is a first time shoulder dislocator, then I would give a conservative management of 3 weeks. And if patient is very young and he is athlete, I would ask him to do MRI right away. But surgical management is not option or not the option in first time dislocators. So yes. It based on the patient profile. If the patient is sports person, then I would advise him MRI. If he is a sedentary lifestyle patient, then we can observe him.
Okay, means certainly MRI is recommended if allowed to do so.
Yes, yes. But the line of management doesn't change.
So very difficult to define a VIP patient because
See, ideally, I think it is a good thing to get a MRI if patient can afford, because we know that if cuff is avulsed, I think we are going to do something for that.
Right.
But I agree, Neha. First time dislocator, no need scientifically also. VIP, affordability, insurance covered, yes, by all means. But scientifically speaking, not really required unless it's a recurrent dislocation, you're planning for some surgical intervention. But good talk. Let's move on to the
Thank
next
you.
one.
Thank you, sir.
Thank
Thank
you.
you very much.
so now may I invite the second speaker for today's session, Dr. Ishani Chaudhary from Akola, and she will be giving a talk on deformity correction for bilateral genu valgum deformity.
Hello, good morning to all the esteemed members and dignitaries of the Vidarbha Orthopaedic Society. Thank you very much, Neha ma'am, for this kind invite to today's clinical meeting. I'd like to extend a delayed Happy International Men's Day to all our colleagues, our seniors, our mentors, and it's so good to see so many women at this meeting today. I'm Dr. Ishani Chaudhary, and I'll be presenting an interesting case of deformity correction in bilateral genu valgum. Right at the start, I'd like to mention that I was completely involved in the process, right from the clinical assessment, the pre-op planning, assisting the surgery, and the rehabilitation and follow-up, but I was not the primary surgeon. However, this was an interesting learning curve for me, and I'd like to share the same. So, presenting a 19-year-old overweight girl who came with this dramatic deformity, and on complete examination with radiographic imaging, with the AP lateral and the full length weight bearing AP X rays, the preoperative planning was done and all the measurements and marking were done using the image suite software, where we marked the mechanical axis deviation, the medial lateral distal femoral angle, and the medial proximal tibial angle. And the deformity was noted both in the tibia as well as the femur on both sides. On the left side, in the femur, it was 5.3 degrees of valgus, and in the tibia, it was 6.5 degrees of valgus. This was the templating done. On the right side, it was approximately 9 degrees in the femur, but less than 3 degrees in the tibia. This is the templating for the right side. Now, as per literature, with such a case after maturity, the options for this girl were, in the femur, there was an option of undergoing a lateral opening wedge distal femoral osteotomy or a medial closing wedge distal femoral osteotomy. We chose to go with the medial closing wedge distal femoral osteotomy with a larger bony contact and better healing. For the tibia, the options were the medial closing wedge osteotomy and the angulation translation osteotomy. I'll just explain why we went with the angulation translation osteotomy in a bit. So this was the proposed plan. One was the initial pre-op planning and then executing the plan. It was decided to to treat the right side first, as the mechanical axis deviation was a gross 100% as opposed to 89% on the left side. Then do something for the tibia and rehabilitate the patient, and after sufficient time go in for the left side. Now, since we started on the right side with the intention of correcting both the femur as well as the tibia in the same setting, a prophylactic lateral popliteal nerve release was done. The patient was in the supine position under tourniquet control. Superficial release of the peroneus longus facial band near the neck of the fibula was done, with a deeper release of the intermuscular septum, which separated the muscles of the anterior and the lateral compartment. Now for the left, because this was done for both the sides, there are images which are given from the left side. On the left side, we conducted a fibular osteotomy below the level of the neck of the fibula. Now addressing the femur, since the DFO, medial closing wedge DFO, was done on both sides, I'll be talking about this procedure at one go. There are images from both the right as well as the left side here. Now, continuing in the supine position with the patient on this is a special L-shaped cut mattress, and the table positioned in such a way that the non-operated leg is extended away, which gave better access to the medial side for the Shyam imaging. This was a special instrumentation used for this case, which was a set of fine osteotomes, a vernier caliper, a curved periosteal elevator to protect the posterior soft tissue as well as the neurovascular bundle, a precision saw with an oscillating tip, along with the tomofix plates. Now, starting off with what we did, starting the incision, after a lateral Shyam image marking with a K-wire, the midpoint between the anterior and the posterior cortices, the incision was taken about 1.5 centimeters above the joint line, extending up to 7 centimeters proximally. The deep fascia was incised, and the vastus medialis was elevated off the medial intermuscular septum, and blunt Hohmann was, and using a blunt Hohmann, the tissue was retracted anteriorly. The periosteum and the soft tissue was gently dissected, and curved periosteal elevator was used for dissection such that one finger breadth access was allowed, and a retractor was placed to protect all the posterior neurovascular structures, which are just about 1.1 centimeter away. Next is the plate positioning with the sleeves and the wire sleeves. So the plate is such that all the four screws of the condylar screws, they were fixed first with the K wires to ensure that the plate is correctly positioned in the AP as well as the proximo-distal direction. The aim of this was to ensure that the inferior screws do not infringe upon the intercondylar notch, and the superior screws do not infringe upon the proposed osteotomy site. Now, the superior wires were left in place, the inferior wires were removed, and a set of 4 wires were inserted converging onto the hinge point of the lateral epicondyle with the intended angle and the wedge base. For the right side, after the templating, the calculation was, it was 10 mm on the right And these wires that we had placed were approximately 14 mm. So that gave about 2 mm on either side to allow for the osteotomy. And for the left side, the wedge base was 6.2 mm. So approximately these wires were about 10 mm apart, allowing 2 mm on either side. Now the posterior 3/4 of the femur was cut with the lines converging towards the lateral epicondyle, just short of 5 mm from the epicondyle. After this, a second biplanar osteotomy cut was taken in, with the anterior going towards the cortex with the anterior 1/4 at an angle more than 90 degrees, approximately 110 degrees, and with the oscillating saw going up to the hinge point. So these are the Shyam images. Earlier, a hinge protection wire was inserted, as you can see here on the Shyam image. So the hinge protection wire was inserted from the distal aspect of the femoral condyle, going across the hinge to protect the hinge and to prevent any fractures. Now, after both the osteotomies were done, the hinge was gently broken and with drill holes by 1.8 mm wires. And very gently and with light gradual compression, the osteotomy was slowly closed. The plate was inserted over the previously left wires of the superior screws of the condylar area under Shyam imaging. 4 5 mm locking screws were inserted in the condylar area, and then a golden screw was placed at the non-locking golden screw was placed just above that, after which the remaining locking screws were placed and then the golden screw was replaced. The work of the golden screw was to close the osteotomy site and bring the bone towards the plate. Now, after checking the mechanical axis in this patient after this procedure and finding it close to 50%, and the technical difficulty of this patient being obese and this surgery having taken a long time, we decided that we'll not do the tibial correction in her case. And if at all it's required later, if the symptoms or the deformity reappears, this was to be done at a later stage. And this was all for the right side. She was later then put on a post-operative rehabilitation protocol, which included partial weight bearing, knee range of motion, and electrical stimulation for the quads. These were her intermediate results. This is about 3 months after the right side was done. Now, next we undertook the left side 6 months after the right side was started. For the left side, again, the templating shows that the valgus was 5.3 degrees in the femur and 6.2 degrees in the tibia. The wedge base was approximately, and 6.2 mm of a wedge for the femur. Now, as the tibial deformity was more on the left side as compared to the femur, and we also noted that there was an overall shortening of 6 mm on the left side more than the right. So the left side was shorter than the right. That's why we didn't want to do two closing wedge osteotomies, and hence for the tibia, the left side was treated with a fixator-assisted angulation translation osteotomy and plating. So first is the fixator setup. So 2 shank pins were placed both in the upper as well as the medial tibia with the Ilizarro rings in such a fashion that the distal ring is slightly laterally translated and also at an angle of 7 degrees. Now, how this is achieved is by calculating with a goniometer intraoperatively and using multiplanar hinges that allow that angulation between the proximal and the distal ring. A horizontal incision was made at the medial tibial face, and a percutaneous osteotomy cut was made at 9 centimeters from the joint line. This is where the cora was found. And when the rings were straightened out, the plan was such that it would cause a medial translation of the distal fragment by just one cortex. The plate was then slid through the incision and fixed in the locking mode and inserted like a MIPO plate under Shyam control. And then after that, the fixator was removed. After which, these were the parameters. So the MLDFA was 86.7, the MPTA was corrected to 85.3, and the mechanical axis came to 54. Now, this is something, then she started on a post-op rehab protocol. Now, what happened in her case was that during the rehab after the right side, she was pain-free post second day of the surgery, after which she started walking well. But what happened is she called us up and she said she's getting pain on the right side, on the outer side, just above the knee. So we suspected a hinge fracture, called her. She's from out of town, so called her and got her X-rays done. And as suspected, it did turn out to be a hinge fracture. So in this case, what we did was we figured that she had started enthusiastically weight bearing more. So I just asked her to restrict her weight bearing to just 10% for the next 6 weeks, and that is all that was done. This took care of that, and it healed well, and no further incidents were reported. Finally, this is the treatment summary for this patient. So the pre-op planning, the execution of the plan in terms of the lateral popliteal release, the medial closing wedge distal femoral osteotomy, the rehab, and then later, approximately 6 months later, again, similar procedure for the left femur and then a fixator-assisted tibial plating. So these were her corrections. On the right side, from 100% MAD, it went to 53. On the left side, from 89%, it went to 54. The MLDFA went from 78.4 to 87.1. And on the left, 81.7 to 86.7. And the MPTA went from 89.9 to 90.9. And on the left side, 95.2 to 85.3. I'm sorry, I bored you with so many numbers. And so this was the clinical picture finally. And these were some of her functional results. Thank you. I would like to, with your permission, ma'am, I'd like to cordially invite you. We are hosting HTO 360, which is a comprehensive conference on high tibial osteotomy next weekend. And all of you are cordially invited for the same. Thank you so much.
Ishani, good case. My quick questions.
Yes.
Number one, why did you not undertake both the limbs together? Was there any particular reason for it? Because anyways, you are going to do an independent procedure. One is fixator controlled thing, other is an open plate. So why not?
So the healing would have taken time, the weight bearing, and it would have been quite essentially healing would have gotten delayed with this. And the weight bearing would have also become a bit of a problem. With her case, especially with the obesity, that was also a confounding factor for doing both together.
Okay. And I see the left side,
Yes, sir.
tibia is far distal. Is it because the cora was so distally placed?
Yes, so the cora was around 8.5 to 9 centimeters distal.
That is great.
Thank you, sir.
Ishani, it's a wonderful case, and
Thank you,
certainly
sir.
must congratulate for ultimate good outcome. So what are your indications for going for dual osteotomy, tibial as well as femoral on the first go? If you do an scanogram, so how do you decide, apart from the routine angle calculation, how do you decide you want to go on the both sides?
Thank you for the question, sir. So at our center, what we do is we only do these full length full length and AP and lateral. But on the full length scanogram, after calculating the mechanical axis deviation and then the MLDFA and the MPTA, once we figured out where and how much is the deformity. And so, for example, in the right side, for example, the femur was much more and the tibia was negligible. It was less than 3 degrees. So we didn't decide to do the tibia in her case. But if the deformity is shown on both the bones, then it's better to go for both bones.
I think the newer plates which has come up, the low profile, the new clip kind of plates, which contour more properly and they allow weight bearing early.
Mhm.
So these are usually nowadays more recommended, at least on the femur, the distal femoral plates, they are doing much better.
Okay, sir.
And I think the lateral opening wedge osteotomies are sometimes having a better results than the technically difficult medial closing wedge. So what is your take on that?
Thank you for this. I wasn't aware of that, but definitely one of the things that happens with the lateral opening wedge is one of the complaints is the implant irritation with the IT band, the friction with the IT band. So definitely this could be one of the things that can help. I wasn't aware. I'll definitely look up more on it.
And I think there was some, hinge fracture in the operative, the Shyam image itself. I think in the intraoperative, if you could make out.
Okay.
So,
So if while closing the osteotomy, there wasn't like the compression was done, the closing of the osteotomy was done, making sure that there was no hinge at that point, hinge fracture at that point.
okay.
Yes.
So any more questions from the delegates?
Yes, sir.
How
planning strategy, whether you want to do first leg, then after some time the second leg, or you want to do both at the same time. So how do you decide that?
So first, on the basis of which limb is showing more deformity. So in this case, we gave more preference to the mechanical axis deviation and then the joint angles. And preferably, we like to go one limb after the other, not both together.
Yeah, after the first head has healed, you take the second one.
Yes, sir. Yes, sir. Definitely after 4 months. Yes, sir.
One more thing.
Yes,
Anil, I will answer that more. In life, difficult problem first, then the easier problem. So the satisfaction is greater, so the patient returns with you. So difficult first, easier later.
If you are planning the dual osteotomy on both sides, so it is not recommended to have 4 surgeries at the one go. But certainly you can go at least 2 procedures in the one go and the second 2 procedures in the second setup. But you can do simultaneous both limb femoral osteotomy in the first instance and then tibial osteotomy at certain interval. So this is another way you can do it.
One more suggestion.
Yes, sir.
This was an elective case and a young patient.
Yes, sir.
And again, you have stressed the patient was obese. Therefore, you had to really choose the surgical options. But I would suggest, this is a suggestion, for elective surgeries, young patient, it is very easy now to reduce 8 to 10 kgs in 2 months by various diet plans. And then you can go ahead and do whatever surgery you want, because this can wait for 2 months also.
Definitely.
So then your choices become more and surgery also becomes relatively easier.
Absolutely.
This is just a suggestion.
Definitely. And sir, for her, we've also advised her to continue on this because that will prevent any further complication and early arthritic changes as well.
Okay, good. Thank you, Ishani. I'm sure Milind will be extremely proud.
Excuse me, sir.
Thank you, sir.
I just want to ask one question.
Sure.
Ma'am, how often do we do a lateral pulmonary nerve release in case of severe genualgum cases? First of all, this was the question. And secondly, instead of going through the medial approach, as you said, if we go through a lateral approach and do a middle logical osteotomy, it will be stable also and there will be no risk of hinge fracture. And in fact, if we translate it distally, if the distal fragment is translated, we can just shave off the lateral femoral condyle, distal femoral condyle. That will be stable as well. And thirdly, we don't have such expensive software as well. We have this alignment views. We usually can't calculate the wedge base. It can be better if we just do simply by just eyeballing, by just inserting a K wire parallel to the joint line and one K wire which is perpendicular femoral shaft. That will also give us a correction as well.
So I'll take up the third question first. Is this software was Carestream image suit is not expensive, and the one thing about these deformity correction cases is that you need some amount of precision and you can't eyeball it, because in her case, for example, we went from 100 to 53 and 54. Now even if that is say, even if you compare it, that still becomes like a 6 to 8 degrees or 8% of error. Now that can be quite a lot, so you can't eyeball these surgeries is number one. Regarding the second one, the first question, can you please repeat?
To a lateral nerve release in case of severe genualgum.
So at our center, we do it as a protocol. And regarding the second one, we haven't done it through that approach, so I'm not aware.
Can I answer?
Yeah, yes, ma'am.
So we do, if it is more than 30 degrees of valgus, then we do a prophylactic. We always do, at my center, we do from lateral approach and a medial closing
That's
wedge.
what
We can do that, and a lot of other centers are also doing that. The third question, even if you don't have a software, you can always take a scanogram and do your mathematics and calculations.
Yes,
But calculation is important. You should not it should not be based on computers, because we teach students in exam they're not going to get computer.
Yes.
But it is necessary to take a scanogram, a properly done scanogram, and calculate and then do, and just not do eyeballing.
Thank you.
Yeah, that's a perfect point that madam has made. So never do with your own eyeball. It's just simple scanogram. You can take a printout of it. Go on for this multiple. Yes, ma'am. You wanted
So
to.
last point, along with the eyeballing, all the genualgum, the elder kids, they have a ligamentous laxity also.
Yeah, the
So
thrust
the
factor.
standing scanogram is much more better than a supine child eyeballing and deciding an on-table correction.
Yeah, even the thrust factor with the ligamentous laxity need to be corrected. And nowadays they are even recommending the single leg stance scanograms, which are much better for your actual visualization. So thank you for this excellent case demonstration. Thank you, Dr. Ishani.
Thank
We'll
you
go
so
with
much.
the third talk now. It's by Dr. Sharmila Tulpule, and she will be speaking on regenerative medicine in orthopedics, present and future. So whether this really works or not, she will be able to answer all our queries, because many companies are coming with many products for this thing in orthopedics.
Button. Okay. Change करो. So, hi everyone. Good morning. Very sorry to bore you with the academics on a Sunday morning, but I hope I can add to some of the insights you already must be having. So, I'm Dr. Sharmila Tulpule, and a little bit background that I'm practicing orthopedician with a shift to regenerative medicine since last around say 5 to 6 years majorly. Almost 50% of my practice now is regenerative orthobiologics, I would say. I have center in Dubai as well as Mumbai, and so Mumbai is very recently opened, and I practice at Saudi German Hospital in Dubai. Fortunately, I had the privilege of working and being associated with world leaders in regenerative medicine, right from Arnold Kaplan, who is the inventor or discoverer of stem cell, I would say, and Dr. Murrell, Dr. Don Buford, and Dr. Ulrich Snyder. And that's how I landed up being extremely fascinated by the field of orthobiologics and regenerative medicine, and been part of a few textbooks on orthobiologics. This is the other one, and we published a lot of research paper recently on orthobiologics, including PRPs, BMAC, adipose stem cells, and the latest one, which is Goldic, which I guess I'll be giving a detailed talk on Goldic in my second talk. But yeah, so starting with regenerative medicine, what is it? It's a very theoretical explanation, not very interesting, but process of regenerating human cells, tissue, organs to restore or establish normal function. Fast evolving branch of regenerative medicine, when it is used in orthopedics, is orthobiologics. And so these are my objectives today, little bit on each topic, various modalities, and is there a substantial evidence? Yes, that we need to really look to, and what is the future? Scope of regenerative, it's being right now rapidly developing in MSK, right from cardiology to neurology to endocrine, and much in oncology also. In the specialty components, I would say, okay, stem cell biology is developing, but gene therapy is the one which is really, really changing the whole scene. And right now, the genes are being edited, cut, and removed by CRISPR technology, and it's very fascinating what they're able to do with single shift of one gene, and I guess that is the future. This is how we classify orthobiologics, acellular, cellular, and gene therapy. We won't be discussing gene therapy because it's at research level right now. Acellular and cellular. Cellular would be stem cells and PRP. PRP does contain cells with platelets as well as leukocytes, so it could be leukocyte rich and poor. Stem cells, adult and embryonic. Embryonic, we are not using in orthobiologics much. Lots need to be researched still, and that's why adult stem cells, they are the ones which are being used in orthobiologics. BMAC, adipose, and allogenic. Acellular orthobiologics is autologous conditioned serum, alpha microglobulins, and Goldic, of which Goldic is the latest one. Both autologous conditioned serum and Goldic has been in use since last around 20-22 years. In at least Europe, it is really being done extensively. So these are my common orthobiologics in my practice. Prolotherapy is just a supportive thing now. It's being used in US since last 60 to 70 years. The disadvantage being it needs multiple sessions and not very long lasting. PRP, I'm sure you all must be aware, and many of you might be using it also. Stem cell therapy and Goldic therapy. So we'll be discussing a bit of each. So interventional orthobiologics would be bridging the gap between simple, non-image guided orthopedic injections and surgery. I guess somebody pointed out the use of ultrasound. I cannot overstress the importance of ultrasound. It's like, once you start using ultrasound in orthopedics, it's like a stethoscope for medicine. It gives phenomenal information every time. Advantage over even an MRI is that it gives you dynamic imaging. So we were discussing supraspinatus and rotator cuff thing. It really changes many times, okay, the decision between non-operative and operative, and we've really been able to make very good distinction in that. So what are the potential areas where we are looking at orthobiologics or regenerative medicine use in orthopedics? Is obviously mostly non-traumatic orthopedics except for sports injuries. Okay, so osteoarthritis, obviously, rheumatoid arthritis and autoimmune diseases, though we don't consider it as a part of orthopedics, it is huge, and we do get always crossover of patients, and that is being extremely giving extremely good results with orthobiologics. All types of tendinosis, right from, of course, tennis elbow, golf elbow, but rotator cuff tears are giving excellent results. We'll get into that a little bit later. Plantar fasciitis, Achilles tendinitis, which is like extremely resistant to any treatment, and nobody likes to, I guess, treat it anymore, gives excellent results. All types of sports injuries, okay, mostly ligament injuries. ACL, I would not be getting into the controversial part, but yes, partial ACL tears have been doing good. And augmentation, okay, that we come to later. Augmentation of all the repairs, either rotator cuff repair or an ACL repair or reconstruction, gives excellent results. In fact, I have a study where we've compared 10-year post follow-up of a rotator cuff tear. We did some 16 cases of rotator cuff tear, which was repaired with biologics and without biologics. And with biologics, it showed excellent result at the end of 10 years. Without biologics, it was just 44%. So there's a paper published on that. Spine, we've been treating recently lumbar and cervical discs with orthobiologics. I'll show some slides if I have. And the last is adjuvant to orthopedic surgeries, as I mentioned. In fact, I ventured into orthobiologics. I started first using orthobiologics as adjuvant, and then went into pure orthobiologics also. So these are some of the indications, I would say. So this is how, I'm not going into the details of what exactly goes on there. It will be too theoretical. But yes, the regenerative treatments, ultimately they reduce the fibrosis. And so the healing is better. A little bit about PRP, which is the most popular orthobiologics right now and very easy to do. So that's a blood plasma enriched with platelets, which are concentrated, contains plasma, WBCs, platelets, and lots of growth factor. The definition, it should be 3 to 5 times platelets than the baseline. It's very rich in growth factors. There are almost more than 1,000 growth factors in each platelet. This is how PRP acts at every level: angiogenesis, collagen 2, cartilage remodeling, hyaluronic acid production and reduces pro-inflammatory cytokines. This is the structure of platelet with basically dense granules and alpha granules, which are the main reservoirs of these growth factors. PRP types would be leukocyte rich and poor. The other would be platelet poor plasma rather than anything. Leukocyte rich and poor, they definitely have very defined indications in which conditions you should actually use leukocyte rich and where it should be leukocyte poor. So we see many times, as you rightly mentioned, that there are so many kits floating around in the market, and what should be a good PRP. This is interesting. Last year, whole last year, I actually went through 26 kits made in India, and we actually researched each one of it, and sadly not even one came to close to being ideal or good PRP also. Okay, so most of them gave platelet poor PRP. Platelet poor plasma, PPP, that is what we call. There were only 2 or 3 kits which gave 1.5 times concentration. Where we are looking at is 5 to 7 times. This is the Indian kits that I'm talking about. There are a little bit more now coming in the market. So PRP dosing is extremely important. Should be between 5 to 7 times. That's our latest work, which is showing that it should be 5 to 7 times the baseline. Not even 3 to 5 that we started with. Commercial kits which use less blood quantity. So how do you know whether this is good or not? If the guy coming and saying that, okay, take 10 ml of blood, concentrate and give it, it's not working. Okay, 10 ml, how much is it going to contain? The baseline platelet count, if it is 2.5, then this is not going to, the glass is not going to produce the platelets inside. Okay, it's not going to go beyond that. So it doesn't work. So 30 ml blood will give around 3 to 4 times platelet concentration. Ideally, for one big joint, it should be 60 ml. Okay, that's one. Second, one shot PRP, no, it doesn't work. All large joints need 3 sessions. That's what our protocol is. And then, of course, there is a lot of things to be explained that, okay, maybe that you'll need a 2-yearly shot again. But that's fine. But then this is the reason why PRPs don't work, or they are inconsistent with results, because the dosing is not right. So we do platelet count in each PRP. We do a pre-procedure CBC and platelet counts as well. So this is how a manual, so we have a manual PRP thing also done, which we many times need to double centrifuge or even triple centrifuge to get the concentration that we want. So it depends on individual skill. So it's better to get a commercial kit if you're not very sure or you're not very well trained on doing how to get it done. Okay, because how to get the leukocyte concentrated in manual needs special training. Again, manual PRP ideally needs a biocabinet to maintain the sterility unless you're doing it in the operation theater. These are some of the recent PRP systems which are giving really good counts. They are all US based. Precise injection technique, I can't overstress the importance of ultrasound guided precise delivery of orthobiologics. Once you got so much, then at least we should know that it is going into the right place where we intend to inject it. Advantages of PRP, they are very obvious. It's repeatable, it's quick, and it's OPD procedure. Going to stem cells in orthopedics, Arnold Kaplan, he is the guy who described it 1969, but now last year he came back and said that look, what I was saying, which is a stem cell, is not really a stem cell. So that's going to change a lot of things in ortho, but he's changed the nomenclature and all. But anyways, stem cell the word has been abused so much that I thought it's better that he changes it now. The stem cell, what is a stem cell? It's a non-specialized cell which self-renews and it can differentiate itself, which means that it can just become anything. This is how it replicates. Types, According to source, it could be embryonic, it could be adult. And the third one is iPSC, which means induced pluripotent stem cells, simply meaning that you can convert the adult stem cell back to embryonic stem cells, because embryonic stem cells have more capacity to get into anything they want to. As you become adult, the capacity becomes little limited. This was in 2010, Japanese inventor. He invented this and he got a Nobel Prize also for this. According to source, it is autologous and allogenic. Allogenic could be umbilical cord and with adult donor with, right now, I think one got approved in Indian market, stem one. So that's an adult allogenic. We use autologous. Either it could be bone marrow, fat, more about fat later, dental pulp, ear pinna, and skin. There is a newer thing in the market which gets stem cells from ear pinna. It is an OPD procedure. It's just being launched in Europe, that you just do a small punch biopsy from ear pinna. It's processed there and then, half an hour, and you inject it back, giving good results according to them. I'll let you know next year, by the way. Types of adult stem cells, adipose stem cells. This is my favorite. Adipose derived stem cells, it could be MFAT, which is micronized fat. So either it could be micro fat or nano fat, depending on the sizing that you do. SVF is stromal vascular fraction, in which you actually use collagenase, that is enzyme digested fat, wherein the stem cells are released from the whole fat structure. And third is culture expanded adipose stem cells. Culture expanded takes longer time, it's very expensive, it needs a very sophisticated setup. Which is better, bone marrow or adipose? Definitely adipose, according to me. They are genetically more stable, longer telomere length. Telomere is the end of chromosome, which denotes the age. Okay, so it is like directly connected with aging. And 1 ml of fat contains 1 lakh to 1 million stem cells, while as 1 ml of bone marrow contains only 50 to 675. So some good use of our fat. This is how it is done. So it's a small mini liposuction procedure, after which we process it. There are 2-3 ways to process it, depends on the kit that you're using, and then it is ready to inject. Recently, like last 4 years, we've been lots into Goldic. Goldic is a very innovative concept and technology. It's giving excellent results in degenerative joint and tendon pathologies, rheumatoid, seronegative arthritis, sports injuries, spine, and now I might add long COVID as well. The concept was developed by Dr. Ulrich Snyder, my very dear friend, in 2000. He's an orthopedic surgeon, German orthopedic surgeon, and a rheumatologist and a scientist and many other things. Started experimenting with reacting gold with blood. I'm going to get into details of Goldic later, so I'm not going to elaborate it too much right now. But gold, with its anti-inflammatory and regenerative properties, he found that it can be effectively used in many inflammatory and degenerative conditions. Now, is there evidence for orthobiologics? There are multiple studies. This is interesting. This Don Buford is an orthopedic surgeon and regenerative medicine specialist in the US, and me and him, in US, everybody used to keep on saying that we need level 1 evidence. So evidence is divided into level 1 to level 6. Level 6 being an expert opinion or a single case study. Level 1 is a randomized controlled trial. And so everybody demands randomized controlled trial as the basis for taking it, whether it is to be taken as evidence or not. So we decided to do a little bit research. We researched 6 top orthopedic journals over 13 months, total 98 issues with 1,425 papers. And what we got is average level of evidence in any top orthopedic journal is level 3. So there's no point in demanding level 1 evidence for orthobiologics, where in orthopedics we are accepting level 3 evidence. But These are the randomized control trials for PRP in osteoarthritis knee. Total 39 RCTs for PRP done till 2022. That's a sizable number. 37 showed very, very positive results. 2 only were inconclusive, where we found that it was PPP, that is platelet poor plasma, but not platelet rich plasma. These were the studies of PRP only for tennis elbow. Total 16 studies till 2017. I guess at least 20 are added. I didn't get the statistics further. 1,076 patients, positive results. RCT in knee osteoarthritis, there are 79 with clear SVF, that is fat, and BMAC stating that it is clearly better. These were only adipose stem cell studies. In 2011, there was only one study. 2019 alone, in 1 year, there were 16 studies published, total of more than 5,000 patients. We did one research in which we combined bone marrow and adipose tissue stem cells and injected. It was total of 302 patients. This was unique because it was in advanced osteoarthritis. Advanced meaning not absolutely advanced, not grade 4 plus, I would say, but grade 3 and 4. Gave excellent results. What is the future? Regenerative medicine is bridging the treatment gaps in orthopedics with lots of evidence coming up. So I would look at it as the innovative technologies filling the treatment gaps. You should not be saying that we are there where surgery is to be totally avoided. There is a point before surgery and after physiotherapy that the patients who don't want to go in for surgery or they are not fit for going for surgery, I think that is where orthobiologics play a very big role. Goldic is very promising, innovative, regenerative and immunomodulatory treatment, and gene therapy is fast developing and it's going to revolutionize non-traumatic orthopedics. This is our email and phone. So we're conducting few courses of regenerative orthobiologics in Mumbai and about Goldic technology as well. Thank you. Anybody who wants to comment or ask, you're welcome. Yeah. 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 So it will depend on which modality we are choosing. Okay, I'll be again giving a small talk on Goldic, and in that I'll better explain how much time it takes. But what we have seen that if you're doing a good PRP treatment, even that can last quite longer. Okay. Personally, what I have seen, good PRP lasts for at least minimum 2 years if it is grade 4. Grade 3, you don't need to do anything actually. It just it gives excellent results with grade 3. After 2 years also, you can repeat. Okay, it's the repeatability of these procedures that's a plus point. Okay, that you can repeat it at n number of times. Okay, the concept is very, very, very simple. That it's your healing factors. You're just concentrating and releasing it where it is needed. Okay, so there is nothing like doing it too much. Okay, there is something like doing it too little, but not too much.
And so another point blank question to you.
Yeah.
Young patient, medial compartment OA, we want to buy time,
Yeah.
we do HTO. Is this going to overlap some results of HTO?
It could.
In terms of buying time, in terms of even rejuvenating the joint.
Absolutely. Absolutely. I'll be showing a few slides later on also. Though osteoarthritis, okay, regeneration per se in bad knee osteoarthritis, we can't prove it every time the thickness being coming back.
Agree.
Okay, that's a very difficult thing. But symptomatic relief, yes. I have seen personally with PRP relief lasting till at least 5 years many times. With Goldic, I have seen it till 8 years also. So we are talking long term now. It's not 6 months or 1 year. Okay.
I think it's a very excellent talk, and that good study of through 2000 papers with level 3 evidence.
Yeah.
They already come out. I wanted to ask, like, there are like 3 or 4 orthopedic, we can convert like chronic tendinopathies or the
Yeah.
tendon ruptures or the soft tissue ruptures or the cartilage problems or the fractures. So among these 4 kind of categories, where do you feel the orthobiologics fits most? Where the results will be much better that we can use routinely?
All these orthobiologics as a routine, as a R protocol, we tell the patients to do all conservative treatments, and if they don't work, this is the second line of treatment. Before going in for surgery, we would always want them to be tried with orthobiologics, and if that fails, then surgery. The best region where you feel okay, it could be one is cartilage, second is tendinopathies, excellent results in tendinopathies, and now we are seeing excellent results in spine. More about that when I talk about it later, okay, in the second talk. But all of them, very exciting results have been in all sports injuries. Sports injuries, return to field, and those who are competitive sports people, again, I'll be showing you few. It has been excellent.
Certainly, I started doing it in the ACL reconstructions, where I'm using the graft just to inject the PRPs. It is certainly getting good results.
Yeah, we've got lots of papers actually that post ACL. Even you use orthobiologics while doing reconstruction. What we have realized now that after 5 years or so, that post ACL reconstruction arthritis, which is a big issue, or any even meniscus surgery you do, and I've seen it landing up with arthritis so many times, that is taken care of by orthobiologics if you're used it immediate post-op. Yeah. Yeah.
Combination of a realignment osteotomy with PRP, or
We
with
are
the
coming up
orthobiologics.
with that. Yeah.
So maybe the results would be much longer
Absolutely.
lasting.
Yeah.
Number one.
Yeah.
Number two, in patients who have osteochondral fractures, where there is metaphyseal fracture extending into the joint, is there any role, like what he said, till with meniscus injury, they are injecting PRP and orthobiologics. So is there any role of orthobiologics in
Yes.
osteochondral fractures?
Osteochondral fractures also. I mean, this is so simple that, when you're doing the surgery, I have done it lots of times, that while doing the surgeries, okay, you just take, if you want to be that simple, you just take blood,
Many
process.
times you need to use bone grafts and iliac crest.
So, but you just need to know how to, process that. That's it.
Can you suggest some simple, they are doing a trauma, lateral condyle depressed, we have an exposed iliac crest. So can you suggest as a simpler way of practicing orthobiologics in our routine orthopedic centers, where we can improve our results in the osteochondral
Absolutely. So PRP would be a very good and very simple option, absolutely simple. Second would be BMAC, bone marrow aspiration concentrate, wherein the only thing is that tibial bone marrow, I mean metaphyseal, won't be of that good quality as compared to posterior. PSI is the best, okay? So that gives the highest number, because as it is, bone marrow has lesser number of stem cells than fat. One, it is very simple for me. I think it is very simple, okay?
To reduce fat also.
And yeah, exactly. I mean, patients are so excited. Scientifically, those are genetically more stable. The adipose stem cells number is very high. So, the survival rate of how many stem cells are not immortal cells. Okay, you are injecting them, they're going to die there. Okay, so more the number of cells are there, it's better. Okay, and basically now we are realizing that with fat there is mechanical advantage also. So initial result with fat is like I would say magical, okay, because the patient with that fat effect gets instant and full yeah, please. It's semi. So many times we have to do a mixing up with PRP, value inject, because otherwise it becomes a little tough. Thank you so much.
Thank you. Thank you very much. And now we move ahead with the fourth talk for today's session. May I invite Dr. Chasanal Rathod from Mumbai, and she will be speaking on growth modulation.
Good morning, everyone, and thank you, Neha, for having us here for this wonderful session. And so it's a very proud thing for me to be part of VOS today. So when I first started my residency as ortho, the first ortho presentation I had done in BosCon. So it feels really good to come back to any meeting of VOS. And when Neha asked this, I was really happy to be here. What I'm going to talk about is growth modulation. It's not very new, but yes, there have been a lot of newer developments and newer techniques in this in the past 15 to 20 years. So being a pediatric orthosurgeon, it gives us an advantage to use the growth of the child to correct these deformities. So earlier, the options to correct deformities in presence of growth, there were staples and also the Metazu technique. And this technique is now back with transphysial, epiphysial screws. This is back. And in early 2000, Peter Stevens first came up with this 8-plate. So he modified the more rigid implant into a more flexible implant, which was the 8-plate. And he visited India very early, and he allowed the local companies to make a remake of his original Orthofix implant into the 8-plate. So the 8-plate has really made the deformity correction very easy. It helps us to control the time, and also it's a reversible procedure as and how needed. And then that's how we could very easily control this. With this small little tool, we can control the growth and correct deformities as wonderfully as possible. So all over, compared to the previous implants, the 8-plate had a better upper hand because one, it's extra physial. Second, it's a flexible implant, unlike the staple. And the screw is a physial implant. It goes into the growth plate. And the staples are known to cause a lot of growth plate injuries at the time of removal. So although it did correct, but because it was a more stiffer implant, it caused physial growth arrest and peripheral physial bars while removal. And hence 8-plate became much more popular with this after following these two previously used implants. So it basically works on this principle where when the plates applied on the side of the deformity, they work as a tension band and allow growth on the opposite side. So if there is a valgus, when these plates are applied on the medial side, they cause an inhibition on this side of the growth and accelerated growth on the opposite side, thereby bringing about the correction. And the common indications for these initially were limb length discrepancy, of course, which could be congenital, post-infective, traumatic, or of course the angular deformities around knee. And now there are a lot of extended indications where growth modulation have been used. So results have been phenomenal. It gives very wonderful results. No doubt it is a wonderful technique in either of the coronal plane deformities. It works very well. And what matters more and what is important is the age, the timing, the choice of implant, the technique, and what is the pathology. It looks very easy that the limb has corrected very well, but when we do a large number of patients, we realize that there is so much more in it and why all these points are important. So I'll quickly take you through few cases or the following points, how growth modulation differs here. So the younger limit or the age limit, so literature describes various younger limits like 2 years, 6 years, 8 years for different etiologies. Like for an infantile blount, Paley's has described it in younger children as 2 years as well. But the problem with younger age group is it causes a premature physeal arrest, and there is a known rebound phenomena. So when these plates are removed, applied in a younger age, the deformities might tend to come back. And of course, the results are not predictable as they would be in the children which we would apply after 8 years of age. The upper limit is, of course, at least 2 years of growth should be remaining before we think of applying these plates. And for girls, it is usually 11, and for boys, it's 13. Although this could vary a lot, and regularly in our practice, we see that these numbers are just not very much reliable. So, and there are various factors like how much growth is remaining, what is the genetic composition of the child, how the family is, what kind of the physis is it? Is it a simple post-rickets pathological, or is it some sort of dysplasia or syndrome or the sick physis? And all this will decide how and when to describe. A very much close, accurate technique which we can use to plan the timing is the Sovgren technique, which helps us to calculate the skeletal age and compare it with the chronological age. It seems very difficult looking at these charts, but luckily, this kind of chart, initially when I was doing my fellowship, the Mount Sinai Hospital had given us a printed thing, and we would just calculate it from there. So we get an elbow x-ray, look at the different physis and get a score. Now it's become very easy at just our fingertips. So there's an app, multiplier app, which is designed by Herzenberg. And it's very easy to just quickly calculate whatever the physis are remaining. So they can be seen here, and from here we get a score. And this score is further applied whether as per the male or female child, we can calculate the chronological age and the skeletal age of the child. So even if the skeletal age of this child is 13.5, although the kid is 11. So he's still at a borderline age, and he might not be a real good candidate for growth modulation considering this calculation technique. So how does it work and how this calculation is going to work? So the mean rate of correction with application of these plates are, for a femur, it will correct around 0.7 to 1 degree per month, and for tibia 0.5. If combined both the plates are applied depending upon the LDFA and the MPTA of the child, it could correct up to 1.5 per month possible. And faster corrections are possible in children who are less than 10 years of age. And the correction rate is a little slower in sick physis. And as I said, this varies a lot depending upon the different etiologies and the pathological physis. So in a case of Blount's, it is well described that in an infantile tibia vara, like I mentioned, that this technique has been popularized by Paley, and he uses it in kids as young as 1.6 to 2, and he says it works well. Although in cases with older kids with Blount's, it might not work same. These plates lead to breakage, and there is of course a physeal bar formation which we see on the medial side, and they don't work very well. Although the correction might be similar, but yes, for the younger kids it works well. Older children, I have used it up to Langenskiol type 3, and it does bring about correction. After type 3, where there is a slope and there is an intraphyseal bar, as well as the physis is not the regular flat physis. After that, we would need deformity correction with an osteotomy or physeal elevation, any sort, whatever is needed based on the deformity. In other dysplasias like a SED or an MED, again, the rate of the growth is very slow. So the literature does describe that it gives good correction, and there are less failures as compared to the Blount's, but it can be used in dysplasias. Some syndromes, like this one, is a child with Ellis-Van Creveld syndrome. The problem here is the physis is conical, plus it has more like a Blount's-like look. And apart from that, if you see the child has other deformities, a windswept deformity, fingers, upper extremity, facial deformity. So these syndromes usually doesn't correct, and it needs a corrective osteotomy, which needs to be in general explained to the parents beforehand that the 8-plate may not work. Apart from that, another sick physis, which is MHE, the exostosis or the multiple hereditary exostosis. So here in this case, along with excision of the exostosis, the correction works very well, be it with 8-plate or screw, and it does wonders. So here I have put a PET screw and we see that it corrects very well. So when we compare these 3 implants, so if we skip the staple and just the screw and the plate, the screw has a little slightly faster correction rate, and it can be used in children where the growth is little less remained, and we are little confused that whether it will correct or not. So screw is little faster as compared to the plate. And although it's not proven in many papers, but yeah, some papers in the literature, they talk about it. So while the previous six phases which I spoke about, there was a little slower rate of correction. Here are some of the sick phases which have excessive growth. So children who with Klippel-Trenaunay syndrome or a congenital hemihypertrophy or some syndromes where the correction is faster, there the Sovgren technique doesn't help. So here this kid, he was although 11-year-old and initial growth plate, he was treated for a limb length discrepancy. But because of the hemihypertrophy, the plates broke. One, because he was that side was growing faster, plus it was a heavier side because of the hemihypertrophy. So in this case, because the growth was faster and he was advised osteotomy and he had taken a couple of opinions, but I thought since he had a faster rate of growth, I did take a chance and revised the plates and put the 8 plates again. He did very well. So initially he had undergone with a little smaller 8 plate. So this time I chose little larger and more sturdier implant. And he still had very less growth. So if you see the olecranon physis has fused and not much of growth left. But because of the hemihypertrophy, he corrected well. And we can see how wonderfully the screws have diverged. And it was almost about to cut out. And here I revised the screw and the remaining growth remaining valgus also got corrected within almost 2 years from the first surgery which he had undergone where the screw broke. And here he was supposed to remove the implant. So important is when the correction happens, we need to remove the implants. If we don't remove and if there's still growth left, then the child might go into an opposite deformity. So this child went into an opposite deformity during the COVID pandemic. I had asked him to get it removed here. And at this point now I have applied a plate on the lateral side on the tibia after removing the medial plates. So important is that a follow-up is very important on these kids. Every 3-month follow-up, even if they are outstation, they are supposed to send a picture, and implant removal is must. Like this girl with the severe deformity, she went into an opposite deformity with a valgus because they were lost to follow-up. So this child is from Wadia, and it is very difficult sometimes to keep a follow-up of children when they are from a setup where we can't follow them up. And that's why follow-up is very important. The ideal time of removal is when the mechanical axis is in between these 2 zones. So we need to draw the growth plate, divide it in 6 zones, and it should be in either of these zones. And slight overcorrection always helps us to correct the rebound phenomena. And this would be like, particularly if the children are young, then a slight overcorrection is always helpful because there is certainly some amount of rebound to be happened. For for limb length discrepancy, with the same app which I described, we can calculate that at what age we can do a growth modulation to fuse on the normal side. So we can lengthen the opposite side if the affected side, if it's more than, the discrepancy is more than 4 centimeters, or if it's less, then the normal side just apply 2 growth plates or do a transphysial screw, or the age-old technique of the Femister technique where the plate is just scraped. So this is a permanent technique. This too can be reversed still. So this was which was done more primitively, and these are now done very regularly and newer techniques which we follow. And this is what I just mentioned. So apart from angular deformities which I have described, the newer deformities which we now use growth modulation are in sagittal plane. So rather than just doing a varus and valgus, now in presence of a fixed flexion deformity around the knee or coxa valga in hips, the growth modulation is being used, particularly in syndromic children and children who have limited ambulation and where we don't want to go for larger osteotomies or more extensive surgeries. This procedure is very helpful. Smaller procedure in particularly kids who are at high risk for anesthesia. All of these kids are literally high risk for anesthesia. So for a knee FFD, the anterior stapling of the distal femoral physis was quite popular with the staples. Again, the problem here was the staples would back out. So additionally, a 8-plate was used. And with the 8-plate, there was lot of patellar tendon irritation and problem with the more synovitis. So the newer one now we perform is putting anterior screws. And this technique has been very nicely described by Professor McCarthy. So this is a child with cerebral palsy and he has undergone a soft tissue procedure. And there are very specific guidelines. We can't use this for all the children. So if the deformity is less than 30 degrees, and after doing a medial hamstring lengthening or a transfer, if the deformity is around 15 to 20 degrees, then only this corrects. Otherwise, there could be some problems with the tibial slopes and the condylar shape. And we can't use it for deformities like 40 degrees or 50. There, we need to perform a distal femoral extension osteotomy. And also the patella needs to be addressed in CP. So this has very specific indications and it works well. So if we look at this, the child was walking in crouch and he had a pathological patellar fracture. Post soft tissue procedure and an epiphysiodesis. And to buy time to do the osteotomy, I've done this anterior screw and he's doing good. So the deformity becomes better and with growth spurt, it doesn't worsen. So that's one of the indication for sagittal plane deformities. And again, it helps us to get away with a lot of larger or extensive osteotomies which would be needed. Other sites for growth modulation, like I said, for coxa valga, similarly for children with CP or mitochondrial disorders where they don't walk but they start developing coxa valga and eventually dislocation of hip. This works very well and some of these I'll just quickly go through. So yeah, so this is how it's performed for a child with coxa valga. And again, this is to be done in very younger kids. It won't work in children like where 2 or 3 years of growth is left. This would work in children like 4 years or 6 years of age. And it helps us to get a very good varus or the caput valga gets corrected and goes into a little bit of vara. Also for hallux valgus, particularly before the adolescent age group, these kids, if we just kind of a permanent epiphysiodesis, just drilling on the growth plate of the base of first metatarsal helps us to correct the hallux valgus, again in a younger age group. So this is one of the papers from my boss and I have seen him performing this and it works wonderful. Okay. So lastly, I would just come up with this slide. So I think I skipped some slides. So yeah. So apart from this, in the upper extremity, cubitus varus has a little bit of role where the growth modulation can be used. And for the spine, the newer techniques, which is now the teether by Zimmer or the scolioteether, where the scoliosis is corrected similarly by growth modulation technique. So these are some of the other sites where this newer technique is being performed. And what is not acceptable is, so this is a 11-year-old child and I and another 2 pediatric orthos had seen this child in our city. And the child went for growth modulation for the tibia vara. And the girl was 11 years and 4 months. She had already attended Menaki and somebody just put 2 staples for her on one leg. And then they asked her to come after 6 months for opposite leg. So this is not what is advised. It should always be done together because we need to remove the implants together. Also, the growth is equal on both the sides. So this is like recent. I have just seen this kid last week and I felt really sad that in spite of all the teaching and we talk about this topic so much over the last 10 years, still we come across this. And the child has almost lost 4 to 5 months now. and they are still waiting for the opposite side. I don't know, it won't get corrected because now they are waiting to remove this and then do this, which is going to add to anesthesia. So ideally the technique is to do it at one go, and if needed femur and tibia both again at one go. So this is not something which is acceptable. And so to conclude, I would say this is a very easy and a very safe technique. If done at the right time, it gives wonderful result. A great follow-up is very important. We can avoid large osteotomies, and the kids can be mobilized very early without missing on any of their school time or play time, and almost nil complications. We have to be cautious that in sick physis or pathological physis, it just doesn't work the way we are expecting, and prior priming of the parents is extremely important. Kids who are nearing skeletal maturity may act little weird, especially girls who have attended menarche may or may not correct. The Sovgren technique is a slight, like a roadmap trying to guide us, but again, like Google tries to confuse us when we reach at the last moment, it does not always work. And non-compliant patients, we have to be really strict with them, and it is a great tool. So that's it. Thank you.
Of course, great talk, Chasan. One quick question. Typically in a patient of, let's say, CP, FFD, how often do you also need to do the soft tissue correction? Because you're going to modulate the growth, skeletal growth for, let's say, a year or 2 years. So how often would you do hamstrings release?
So, sir, this technique has been advised to be done if there is a residual deformity post hamstring lengthening. So after doing the hamstring lengthening on table, if we see that there is a residual deformity, then this screw should be inserted.
I think that's an excellent talk. You have covered a good synopsis of whole of the growth modulation. I just wanted to ask is like you have done the index surgery, then how do you do your regular follow-ups, the scanograms, the clinical evaluation, and when do you want to intervene in between?
Yeah. So the regular follow-ups are at 3 months, and the scanogram is just prior to removal of implant, that too if the patient affords, because it's many a times it's quite expensive, like it costs 6 to 8,000. So not all patients are okay doing a scanogram. But kids, we are able to get a single length X-ray most of the times in the hospital. So 3 monthly follow-up post surgery, and after like nearing 1 year or so, it's a regular 1 monthly. They send me pictures on WhatsApp and again meet me at 2 or 3 months.
Okay, any more questions
There's
from the
one
delegates?
behind. Yeah. Hello, sir. Good evening. Good afternoon, sir. Yeah, it's not going to work.
What is the age? At what time you are going to do the surgery? So that emphasis has to be by all the, the surgeon who is operating. And secondly, follow what you have said, because in COVID, you had couple of, even we had couple of patients.
So I had 4 or 5 children in opposite deformities during COVID, and they were not ready to come for implant removal. Of course, there were no beds and we couldn't force. So all I have revised, 4 of them put opposite plates for opposite deformities now. And I think the app is very easy, and if anyone, it's a simple procedure, and if anyone wants to do, using the app is like pretty easy and will guide very well, like sir mentioned.
Excellent talk.
Thank you.
Yeah, thank you, Dr. Chasanal.
Ma'am, very
I
good
think we
morning.
have one
Ma'am, one question is, ma'am, if the patient is appearing just near the maturity, with 2 years of growth remaining, so what are your views regarding the divergence of the screw? Shall we put the screws more divergent so that the deformity gets corrected very fast?
Yeah, so the screws always have to be, to start with, they are slightly divergent. If 2 years are remaining, that's an ample time. If you think that 8 months, 9 months are left, then don't put 8 plate. Do the PET screw. That will correct it faster within 6 or 8 months. Thank you.
Thank you. And now we move ahead for the next talk. This is the 5th talk for this first session. And I invite Dr. Binoti Sheth, madam. And she will be having this very interesting talk on what's new in supracondylar humerus fractures in children.
Yeah, so good morning, everyone. And I think this is a topic, I think, which almost everyone must be dealing with. So I have a hard task to give you something new in supracondylar. So I think all of you have dealt with supracondylar fractures in your practice because it is one of the commonest fracture children. Also one of the common fracture which requires a surgical intervention. But still, I'm sure you'll agree that we keep seeing cases coming with complications of supracondylar. We see patients with cubitus varus. We see patients coming with neurovascular injuries. So somewhere my job is to give you something new, some new insights in your day-to-day management, which can help us improve the management and prevent complications. So these are the cases which come to us time and again. And before going to the new, what's new, let's revise just few slides about, I think all of you know that it is of mainly two types. You have the extension type, which is very common, almost 98% because of fallen outstretched hand. And you have the rarer flexion type to direct fall. Many of you must be aware of this Gartland classification where we divide into type 1, which is undisplaced, just identified by fat pet signs, which are treated conservatively. These are type 2, which are hinged posteriorly. You have an intact posterior cortex where the treatment is little controversial, whether to operate or conserve. And these are the common type 3 displaced fractures, which are treated by closed reduction and K-wire fixation. And we always prefer lateral wires, and we want to prevent doing medial wire unless indicated because there are chances of iatrogenic ulnar nerve injury. So what's new in this classification? Well, Wilkins has divided this type 2 into two types, type 2A and 2B. So the type 2A is where it is not much rotated. The distal fragment is not much rotated or translated, whereas type 2B is the one where the distal fragment is little more rotated and translated. So this has made our job easier. So when it is going to be type 2A, we are going to treat it conservatively, whereas when it is type 2B, it requires management like type 3, which is surgical closed reduction and K-wire fixation. Also, there is a new type, type 4, which is described by Lee et al., which is an extremely unstable variety of a fracture. So when you go take these patients and they look like type 3 displaced fracture, when you take him under Shyam for reduction, once you flex, the distal fragment goes into flexion, and on extension, it goes into extension. So what it indicates is that it is an extremely unstable variety of fracture, and there is an incompetent periosteal hinge all around. So there, reducing the fracture, maintaining the reduction while doing K-wire is going to be very difficult. So what is a technical tip to deal with this type of fractures? Well, you require some special reduction technique. Here you're going to use K-wire as a joystick in your distal fragment. So that will give you some control over the distal fragment. And then using that as a joystick, you can reduce and then pass your definitive K-wires. Secondly, normally when we reduce the fracture, we take our C-arm views and we rotate the elbow to take the lateral X-ray. Because this one being an unstable variety, it is advisable that you should not rotate the C-arm, you should not rotate the elbow, but you rotate the C-arm to take your lateral views, and thereby you assure that the reduction is maintained while you are pinning. Another tip, when you're seeing the X-ray, you must always look for this medial comminution on AP X-ray. So irrespective of the variety, the type of Gartland type, if you see that there is medial comminution, it signifies malrotation in the frontal plane. And these are likely to collapse into varus. So always in these types, you would fix it with a medial K-wire. As I told you earlier, we try and avoid, but these are the ones, unless you fix the medial column, they will collapse into varus. So this is an indication for a medial wire. And lastly, there is another classification which is described called as Bach classification, which is based on the fracture pattern. So your typical supracondylar fracture is going to be here. But there are 4 different types on coronal AP view. This is a one which is quite low supracondylar. So here again, the fixation is going to be by cross wires, and these have high propensity for developing avascular necrosis of trochlea because of the fracture itself, which is quite low. So you have to prime the relatives that this could be a possible complication, which is not because of your intervention, but it is because of the fracture anatomy itself. Then there is this lateral oblique type of a fracture where the fracture line is oblique and the proximal line is lateral. So this will be fixed by 2 lateral oblique divergent wires. This is a medial oblique where the proximal extent of the fracture line goes medially. So here Putting a lateral wire will not be mechanically stable. So here are the ones, again, you require putting a medial wire. And this is a high supracondylar. Again, just putting lateral divergent wires will be difficult, and you require a cross wire. Similarly, on the lateral view, you can have a low sagittal or a oblique sagittal view, and the oblique ones are going to be more unstable. So next time when you look at a child with supracondylar, don't just look at the Gartland type, but look into these common classification variations in order to decide your management. Now coming to what's new in management. So we all know how we reduce closely the supracondylar. We give traction, first give the coronal alignment correction, and then flex the elbow, pushing olecranon and do the sagittal correction. Once you have reduced, it is very important to assess your reduction before going for fixation. So on your AP Jones view, you have to see whether you have restored your Bowman's angle or no. And on the lateral view, you must see whether the anterior humeral line passes through the middle third of the capitulum and whether your lateral humerocondylar angle is maintained within the normal acceptable limits. AP and lateral view are not sufficient. You have to take oblique views also. You take internal oblique view to see the lateral column, and you take the external oblique to see the medial column. Because these column views are going to give you an idea whether there is any rotational component which cannot be seen on 2 dimension when you take only AP and lateral. So the column views are equally important to decide your rotation. And also there is a new paper which has come up in JPO 21, which tells about the assessment of lateral rotation percentage for the rotational deformity of the elbow. So this is a simple technique. You take a lateral view, and if you see this proximal medial spike, you divide that spike width with the distal fragment width. That will give you the lateral rotation percentage. And for every 1 to 2% increase in lateral rotation percentage, there is a 1 degree increase in rotational deformity. So never accept this proximal spike, which suggests that there could be a residual rotational deformity. What if you don't get your closed reduction always? Sometimes there is too much of swelling or the fracture is severely displaced. So there are certain maneuvers which are described for closed reduction of these difficult pediatric supracondylar fractures. One of it is a joystick method. So in this, you pass a K-wire proximally from the lateral to medial cortex just at the insertion of the deltoid, and that wire then controls your proximal fragment, and you can maneuver and have a better reduction. This is a very significantly displaced fracture like this, where closed reduction may not be possible, using a joystick wire, that is the wire which is controlling the proximal fragment, getting the reduction and then passing the wire. So in this case, a good reduction was achieved and open reduction was avoided. Again, in some cases, you can use like a leverage technique. So here, you identify the site of the fracture, make a small posterior 5 millimeter incision, pass a blunt K-wire, thick K-wire, and with that, you lever the proximal fragment, and then you reduce, like how you do a joystick maneuver and a technique intrafocal pinning for your distal radius. Similarly, you can do this technique for supracondylar fractures when they are irreducible by normal close reduction methods. So there, a difficult supracondylar like this was treated by leverage technique, and again, we could get away with close reduction. Now, flexion type of a supracondylar, though rare, are sometimes difficult to reduce close because you have to reduce in extension and then passing the pins become difficult. So there is a technique described in JPO 2017 where you use a temporary trans-olecranon pin before doing the passing the definitive pins. So this is a flexion type of a supracondylar fracture. So what you do, you reduce in extension, and then in about 60-70 degrees of extension, you pass a trans-olecranon pin, which gives you a temporary axial stability. And then with that, you can still correct your varus valgus on coronal plane and then pass the definitive wires. And at the end of it, you take out that olecranon pin. So this is a technique where in flexion type also, you can do a close reduction and you can have a good result. Now, once you've achieved reduction, assessed a good reduction, next step is to do the pinning. So again, it is controversial whether to do cross pins, divergent pins, parallel pins, and various biomechanical studies have been done, and it is said that 3 lateral divergent pins provide the same torsional stability as the cross pin. So always, unless indicated, avoid a medial pin. So what is a good fixation? Because once you have reduced, equally important is to maintain the reduction with your good fixation. So the humerus is again divided into two columns, and medial and lateral columns both have to be held with K wire. And the medial wire is preferred to be passed trans-olecranon, means going through the olecranon fossa, which in effect will have 4 cortex perches, 1, 2, 3, and 4, so which becomes a very stable wire. So what is a good fixation? At least you should have 2 wire, and given a choice, you can put 3. Engage both the fragments, have at least 2 cortices, and one of them at least 4 cortex perches. And the wires have to be divergent, so minimum 2 to 8 millimeter separation at the fracture site. As I told you earlier, the indications for medial pin are very specific. Only if you have medial column comminution or a medial oblique type of a fracture, or very low and very high supracondylar fracture. Again, another interesting thing which has come up in this new JPO is to do an internal rotation stress test to check whether it requires a third K wire for stability. So what you do normally when you take a lateral view, you externally rotate and take the lateral view. Here you internally rotate the shoulder and then give us internal rotation stress at the fracture site. So look at this fracture on lateral view, it was looking as if well reduced, but when it was done internally rotated, there was this big spike. And this showed that this fixation with 2 wires is still not stable, and that required a third wire, and that led to stability and ultimately a good result. So all these small tips in your management can help us giving a good outcome. But at the end of it, still, as we said, we still keep seeing patients coming with this cubitus varus deformity. So is it just a cosmetic deformity? There's a very nice paper which has come up, which is where Christine, who has studied the actual biomechanics, and it is said that it is not just a crooked arm. When you have a cubitus varus, the whole triceps force acts medially. There is change in the biomechanical axis. And because of this medial acting of the triceps pull, there is chronic overload on the lateral side. There is lateral collateral ligament attenuation, and that leads to a posterolateral rotatory instability. So when the patients come, they come for cosmesis, but we should understand that it is not just a cosmetic problem. There is a biomechanical problem, and all problems can occur with cubitus varus, like snapping of medial head of triceps, tardy ulnar neuropathy, secondary lateral condyle fractures, AVN of the distal humerus epiphysis, and eventually in long run even arthritis of the elbow joint. You all might have heard of this classical French osteotomy, which is lateral close wedge osteotomy. What happens with that is when you correct it laterally, that leads to a big lateral bump when you're just hinging it on a medial cortex. So in order to prevent that lateral bulge and pseudovarus, you have to do a translation also. So you do a angulation translation, which can help in a good correction and avoids that lateral bump and a pseudovarus. And again, there a new technique has been described where instead of going transverse, you do this oblique osteotomy. And this oblique osteotomy has 2 advantages. One is that it increases the contact surface and makes it little more stable, and you are avoiding that lateral bulge and a lateral spur. So this is what we follow now, doing an oblique osteotomy for cubitus varus. And of course, with technology advancement, there are now 3D corrective osteotomy using custom-made templates, which gives you the 100% accurate reduction, but again, they are more advanced. So in the end, let me first congratulate and thank Neha and Vidarbha Orthopaedic Association for including this innovative topic and having this innovative idea of having all female faculty, because innovations are always there. Like here in supracondylar, classification better helps us in better understanding of the fracture and planning of treatment. All the technical tips, the newer ones, can help us having a successful reduction. The optimum fixation will help us in maintaining the reduction till union. And in cubitus varus, again, a detailed understanding, newer concepts of pathoanatomy can convince the parents better for deformity correction, and with proper technique, we can have optimum outcome. Thank you so much.
In fact, it is our privilege to have HOD from Shyam Hospital, Mumbai, Dr. Binoti Sheth.
I'm still HOU, head of unit.
From the Shyam Hospital to come to Nagpur for this wonderful session, and you have certainly given good insights for these newer techniques. So never a role for any open reduction in almost.
Yeah, so try and avoid, but there are certain indications. For example, if you have a neurovascular injury, any interposition of any periosteum or any soft tissue where you're not getting it, then you always have to do, but keep it as a last resort. Try and avoid because it has its own complications.
So may I now invite the comments from Dr. Chandak sir and Shingade sir.
If required to open reduction, what is the preferred approach now?
Yeah, so the preferred approach is an anterior lazy S incision. And we always say that wherever your proximal spike is, that is where you open. So most of the time it is an extension type and a posteromedial fragment. So the proximal spike is enterolateral. So that is where you open because that is one which is causing the impingement on the soft tissue. So this is now proven that you go by the proximal spike, but most of the time it is anterior. It has certain advantages. It gives you a better approach to the neurovascular if that is the indication. Secondly, you're not violating the periosteum posteriorly because that is the intact periosteum. Fracture is hinged posteriorly. You don't want to violate which is already existing. And posterior approach leads to more stiffness. So the anterior approach is preferred. Enteromedial, enterolateral, depending on the spike.
Binoti, excellent talk.
Thank you.
Most of the colleagues over here, they are practicing in either a small nursing home and they don't have the facility of the vascular surgeon. So could you just give a brief outline how in Sion you are practicing as far as the vessel injuries are concerned with supracondylar humerus?
Yeah, so it's a topic in itself. So I didn't specifically cover because you can't
Just
cover
small tips
everything.
if you
Yeah,
can
so
give.
basically pink pulseless ones can be observed. If you have a definite pale and pulseless, then you have to have intervention. And if you're not having equipped with your center, you have to refer to a higher center. So pink pulseless can be conserved. So you go more by perfusion and not just by pulse. You can have some smaller things like Doppler studies or, pulse oximeter. These things are available most of the places. But if any doubt, then again, you can't wait. And these are the ones which have to be done urgently. Okay.
So in addition to that, further question. So with vascular injury documented with this fracture, how do you approach like the fixation of fracture to a different approach posteriorly then brachial?
So again, with the neurovascular, it will be more of anterior only because your bundle is more anterior. It is that.
So the fracture fixation through the same.
Yes, same thing.
Approach.
Yeah.
You attempt a close reduction.
So again, there are controversy, but in children, depending upon the age, if it's a very young child, then within 7-10 days, he starts uniting. So then you have to take a call whether you want to allow it to malunite and then do a corrective osteotomy or you want to intervene. But I would say personally that if you judge the reduction, if it's any way you think that it's going to malunite, better to do it now than wait and do a surgery because you're not going to avoid surgery. But if it is, say, within the acceptable limit, for that matter, let me tell you, it is not always 100% anatomical. You can accept some amount of translation. So about 25% of translation, not angulation, is acceptable. You have translated in AP and lateral view, that can still unite. But if it's angulated, if it's too much rotated, child is anyway going to land up with rotational deformity. You counsel the parents, tell whether you want to do it now. And as I said, cubitus varus is not just cosmetic, can have a lot of problems. If they're anyway going to require surgery, might as well do it now and do an easier surgery. So you have to individualize. There is no one particular answer. Yes. So there is a Dorgan spinning where you want a medial pin for stability, but you don't want to take any chance of ulnar nerve. Then you do from proximal to distal. So like a Dorgan pin, which is it called. But again, there you are again going to risk radial nerve unless you are very, very specific. So what is recommended is when there is an indication for medial pin, first you put a lateral pin, stabilize it to some extent, then you extend the elbow to some extent, make a small incision, go right till the bone so that you are not taking a chance, and then you can use a drill sleeve and then drill it. So you are avoiding the ulnar nerve. So I don't use personally Dorgan pin, but some people do use it. But there, if you're using that, again, you have to be short of the epiphysis. And again, you can't go too high. Otherwise, radial nerve will be in danger.
So if there are no further questions, I thank you, Dr.
Thank
Binoti
you.
ma'am, for this excellent talk and all the discussion. So we now move ahead for the last talk for this first session. May I invite Dr. Gauri Patki, who is from Rajawadi Hospital, Mumbai. and she will be presenting an interesting case with a novel approach for the infective non-union.
Good morning to everyone. I'm Dr. Gauri. I have just finished my residency from Scion Hospital, Mumbai. And I'm trying to present a very interesting case, which is also a rare case, which was managed with one new approach. And I have seen this case when I was a resident and I was working under Dr. Binoti ma'am. I will be presenting this case with her permission. So this was a case of 25-year-old male patient who was right hand dominant, and patient had history of road traffic accidents 2 years ago and sustained right-sided radius ulnar shaft fracture, which was a closed fracture. It was managed with open reduction and internal fixation with LCDCP plate for both radius and ulna. But 3 months after primary surgery, patient complained of discharge from a radius side, for which infection was suspected and radial side plate was removed 3 months after primary surgery. Later on, after second surgery, X-ray we can see in the slide. Later on, ulna plate was also removed after 7 months of index surgery. So when patient presented, he had already underwent 3 surgeries, and this was the X-ray picture on presentation. As we can see in the X-ray, there is resorption of radial shaft, gap non-union, and significant overriding of ulna. This was clinical picture where we can see sinus, discharging bony spicules, and radial club hand like deformity was also present. Because of previous surgeries, old healed scars were also present. And on laboratory investigations, the picture mimicked that of chronic osteomyelitis with ESR 60, CRP12, and leukocyte count found to be 8,000. So in this case, there were multiple problems to handle at a time. The two most notorious problems were chronic infection and gap non-union of radius. Along with that, there is deformity and unstable wrist joint because of disruption of distal radioulnar joint. Looking upon literature, there were various management options for this case, one of which was using iliac crest bone graft, cancellous bone graft after thorough debridement. So this surgery, according to that paper, was done in 2 stages, where radius plating was done after thorough debridement and iliac crest bone grafting was done in the first stage, and second stage ulnar shortening was done to handle DRUJ disruption, and restoration was done. Another option was to use either vascularized or non-vascularized fibula graft. This surgery was also done in 2 stages. In the first stage, to maintain the length and DRUJ dynamics, they used external fixator and thorough debridement was done after adequate antibiotic covering. The second stage was performed, in which non-vascularized fibula graft was used and was fixed with intramedullary K-wire. The third paper we could find was deformity correction using Elizaro's apparatus, gradual correction of radial deviation, and later on the proximal osteotomy was done following bone transport. And last option was there, which was used as a salvage option, is creation of one bone forearm, where distal radioulnar joint is also preserved and the length of ulna which is intact was used. So what was actually done for this case, what we did was, in first stage, a thorough debridement was done, and using the newer technique, which I'll be talking about in a bit, in 2019, called Masculates induced membrane technique, we used after debridement a cement spacer. In this case, antibiotics were vancomycin and tobramycin were there in cement spacer itself, and after insertion of cement spacer in first stage itself, stabilization was done using radial plating. As a part of debridement, excision of sinus tract, excision of bony spicules was done. Intraoperative specimens were sent to identify the organism, and as we can see in the slide, the sclerotic ends of bone were present. All of those were removed, and cement spacer with plating was done. This is X-ray picture. At this time, nothing was done for ulnar styloid and DRUJ mechanics. Later on, we found that the organism was MRSA, methicillin-resistant Staphylococcus aureus. So according to sensitivity, 6 weeks of antibiotics were given. After laboratory parameters came to normal, second stage surgery was done. In this, basically, gap non-union and overriding of ulna were managed. So cement spacer removal was done, and there is induced membrane, which is a biological membrane. After incising the membrane, now we tried for bone grafting. Radial defect was found to be 3.5 centimeter, and now to fill this 3.5 centimeter of void, ulnar shortening was done. Osteotomy of ulna was done distally. The space left distally was about so that we could insert 2 screws there. And ulna osteotomy at distal shaft was done, and the ulna strut bone graft, which was just taken out, was inserted in the pseudo membrane formed on the radial side, and ulna docking was done with plate. So in the second stage, we used ulna strut graft in the radial defect. So this was 3 months post-operative final outcome, in which we can see good union in both radius as well as ulna side, and deformity is corrected. Patient also had good functional outcome. So to summarize, this technique used basically 2 stages. The first stage, from which was Masculates induced membrane technique. The initial, according to the paper, initial technique did not actually recommend cement spacer with antibiotics, but in this case we had used cement spacer with antibiotic, and bridging plate fixation according to the technique was done. So basically cement spacer insertion incited foreign body reaction, which led to formation of membrane. The membrane was highly vascular, had synovial epithelium, and it provided biological atmosphere for the inserted bone graft to get incorporated nicely. And later on, as I said, autologous bone graft of ulna strut was used. And secondly, in second stage, ulna shortening was done. The same bone graft was used in radial defect. So it was a simple procedure, no graft side comorbidity as it was in iliac crest bone graft or fibula bone graft. It was not there in this particular procedure, and patient also had good functional outcome. Similar paper was presented in which 4 cases using this similar technique were demonstrated. With permission of ma'am, I have included it. And I would like to thank everyone for giving me this opportunity to present on such a big platform. And this has been my very first presentation. I thank you all for this opportunity.
Well done and congratulations. I think it's a great technique, very successfully used. Just one quick question. Why did you think of adding antibiotic and thinking that cement spacer with antibiotic would work the same way? Because the apprehension would have been the induced membrane might not be behaving similar way in the presence of antibiotic in the cement. Binoti, did you not have that apprehension? I would be a little scared.
We thought, that better bombard it. We just took a chance and it worked. Thick
It
and
was
good.
similar.
Yeah.
The unique approach to use ulna the same side. But have you any apprehension of the length of ulna which you to dissect and the gap? Is it matching the same way you are done preoperatively that planning?
Yeah, because in this case it was too high riding, so we could get the whole thing. Otherwise, we would have shortened. Per limb, you are not worried much about the length. Rather than violating other sides, would have shortened radius further.
That's a very unique and very
so
novel
what
approach.
we could get, and we have used this even in pediatric patients. One or two of our patients are pediatric, which have also given similar results. 6 weeks for the spacer too.
With the spacer in situ, you prefer some external fixator or always a plate inside?
Yeah, again, so I would in fact expecting that some question on, you're not worried about plate internal fixation, but the external fixator has its own set of complications. In our set of patients, to take care of external fixator is very, very difficult. They invariably land up and violate the remaining radius also. So we took a chance and
But still with the plate inside sometimes but in upper limb radius, I feel that is additional good method of fixation. Chandak sir, your opinion, in lower limb mostly we don't use inside. Humerus sometimes the internal.
As has been emphasized, for infection control, 4 things are important. One is adequate debridement. Stability is also one of the very important factor for infection control. What plate does is put stability.
External fixators for forearm are messy. They have their own set of problems.
And they have been immobilized and plated, so the bone itself is very porotic. So you don't get the hold, you will not get stability, infection will not get under control. So
Any more questions for this last talk? So yeah, now I thank all the 6 speakers whom I met virtually during all our previous Anmol series webinars. The Master Child by Dr. Gadigone sir, initiated by Dr. Neha and all the team. So I thank you all again for this first session. Thank you very much. May I invite now Neha for this further proceedings.
Thank you. Thank you for the wonderful presentations, all the faculties. Thank you, our chairpersons, Dr. Babulkar sir and Dr. Manoj Paukar sir. So before we proceed for our next session, I would, Dr. Ishani would like to go early. So I would just invite our chairpersons to felicitate Ishani. So without much time, we'll move on to our next session, which is a session on expert views. There are 2 experts, Dr. Binoti ma'am and Dr. Gadegone sir. Each one will present their views, and then after that, they'll discuss or maybe debate. So for chairperson for this session is Dr. Viraj Chingade sir. He's a pediatric orthopedician, renowned pediatric orthopedician from Nagpur. Dr. Viraj sir, please. Our first speaker is Dr. Binoti ma'am.
So thank you. At the outset, I say that, sir, it's going to be a friendly debate. It was good that I have been told first, because after sir raises his voice, I think my voice will not be heard. So let me finish mine first. So another interesting thing, I think, which again, trauma is for everyone. All of you see a lot of patients coming with forearm fractures in age groups. And we have been given very specific topic, which is a forearm shaft fracture, and in children between 8 to 14 years of age. So they are pre-adolescent, not very young, not adolescent, but a pre-adolescent age group. And I'm going to talk for operative treatment. So the goal of treatment in forearm fractures is to attain satisfactory union without having any cosmetic deformity or forearm stiffness. At the end of it, we want to have a good looking forearm, no ulnar bowing, and the child should have good views, good movements, and no stiffness. So how do we achieve this goal? Whether by conservative means, that is just by plaster, reduction and plaster, or by operative, nailing technique, is what are going to be our views. So especially this dilemma occurs more in this 8 to 14 years age group, because as per the acceptability criteria laid down by Price et al., you have very little scope for acceptance. You just can accept about 10 degrees of angulation and just a partial loss of radial bow, because the rate of angular correction is just about 1 to 2 degrees per year. So if you are left with more angular deformities, don't think that everything will remodel in child. And a very recent paper talks about what alignment is acceptable for radius shaft at what age. You see that newer kids and today's generation children are involved in all these activities, like using laptop, using mouse, using fork and knife, and using sports, using use of ball while catching and doing a lot of activities. And for them, it requires near anatomic alignment of radius with almost normal restoration of radial bow, because unless what we've been taught 50 degrees pronation supination is what is required for most activities, the newer evidence says that you require minimum 65 degrees of pronation and almost 90 degrees of supination. So look at this child, say a 10-year-old male child with middle third, lower third radius ulnar shaft fracture. You are very happy, you want to reduce it closed, got good day one reduction, and you've given a good plaster. But when you see them for follow-up, these are very, very common that they again redisplace. And then you are in dilemma because they have already started uniting. The angular deformity is not acceptable. What do you do now? So loss of reduction is a very, very common complication of forearm shaft fracture to an extent of 7 to 39%. So almost 1 in every 3 patients on follow-up can come with redisplacement. And there are certain predisposing factors like age more than 10 years, initial grade displacement, more displaced fracture to start with, radius and ulna, both fractures almost at same level. And all these factors are not in our control. It is the fracture itself. What is in our control is to give a good reduction. So if you have inadequate initial reduction or a poor cast, they are again more prone for redisplacement. And a good cast means you should have a very good cast with almost elbowed at 90 degrees with good intraosseous 3-point molding. You should have your cast index maintained less than 0.7. And not just cast index, there are so many indices described: gap index, padding index, 3-point index. If all these indexes are not within their normal range, they are going to redisplace. So how easy it is to do this and follow into these criteria? So a comparative study which was done talking about complications and radiographic outcomes of both bone forearm fractures with conservative and operative treatment has concluded that complication rate of fractures were twice as common after non-invasive, that means after conservative, than after invasive treatment. As against, there are papers, multiple papers even in recent journals, which have said that flexible intramedullary nailing is an excellent implant which combines stability and elasticity. So for forearm shaft fractures in these preschool children, there are certain indications for surgery. You can't say that everything will heal with plaster. If it's an irreducible fracture due to soft tissue interposition, if there is loss of reduction, if you have an unstable fracture pattern like a complete diaphyseal fracture or segmental comminuted fracture, floating elbow, all these are very difficult to maintain just in plaster. You may get a good reduction, but what about maintenance? Unless you maintain till they unite, they are not going to give you the desirable goal. And this nailing technique is a very, very simple technique, and it's a very minimally invasive technique. This requires small incision. For the radial entry, you take either a dorsal or a lateral incision, have a small, go above the physis, just drill with the awl, get an entry inside, pass the pre-bent nail till the fracture side, do your close reduction, go across the fracture. Similarly for ulna, make an entry about 2 centimeters away from the physis, enter the canal, go again till the fracture site, reduce, and you get very good result. This is the picture just at the time of suture removal. See small scars almost having near normal range just at 2 weeks of post surgery. So these thin nails provide a good tension frame around the fracture, and at the same time they allow micro motion, which again stimulates healing. So it gives stability as well as elasticity, and you get this excellent radiological union in just 2 to 3 months. And after implant removal, you are assured of good result and good outcome, no cosmetic deformity and good function. Every technique has their complications. Even nailing has their complications, like wound infections, or if sometimes the nail is proud, it can cause soft tissue irritation, bursitis. If you are not careful about your entry, you may injure superficial radial nerve for your lateral entry or a EPL tendon by dorsal entry, delayed union. But let me tell you, majority of these are technique related complications. If you follow the technique well, then you are not going to land up in these complications. And these are simple tips and tricks. If you follow, then you can avoid complication. The bone that is easiest to reduce should be rodded first, so you get enough alignment so the other side becomes easier. For nail entry, always avoid the physis, so go away from the physis. Be careful of your EPL tendon, know the anatomy. Make a small incision, dissect, isolate, and then pass your nail. You should not give repeated attempts at close nailing. By more than 3 attempts, if you're not going a close reduction, be ready to do a small mini open at the fracture site and reduce it under vision and then pass. Because if you do repeated attempts, you can have compartment syndrome. So you do have complications, but they can be tackled and avoided if you follow the technique well. Well, some of you may say that becomes costly. Plaster is very cheap. You want to, patients don't afford your nails. But nails are not that costly. Even titanium nail comes as about 2,500 to 1,000 rupees. And there are papers that even you can do a single bone fixation, that also can give you sufficient stability. So this very recent paper from IGO says that single bone nailing is a suitable alternative. It has advantage of less time in surgery and less cost without compromising the final functional outcome. So you can again lessen the cost. Both are going to require anesthesia. This surgery is very quick, so the time also will not be too much. And your follow-up visits, x-rays, plaster cost can compensate for this surgery cost. So this was one case where only radius was nailed and still you have got a very good result and optimum functional outcome. Some of you may argue that you require a second surgery for nail removal. So, well, there are innovations we've already seen in the morning. So, there are these very recent papers coming up with biodegradable intramedullary nailing for forearm fractures in children, where the nails will disintegrate and you will not require any implant removal. So, this is going to be maybe the next time talks about more biology and more biodegradable things. So, friends, advantages of elastic stable intramedullary nailing for forearm shaft fractures are very many. It's a minimally invasive technique, small incisions, short operative time, minimal blood loss. Loss of reduction is rare because you have internally fixed them. There is less need for post-operative immobilization, less follow-up visits and x-rays, early mobility and return to school. Imagine these are pre-adolescent children. You cannot keep them in bed with plaster. Not using upper limb will be punishment for them, and you have excellent functional results. So what's your choice? You want to take a chance with conservative treatment and may end up with this, or you want to do a simple procedure, follow the steps and have the optimum outcome. Thank you so much.
Excellent talk, Binoti. I think we'll take the questions after sir's talk is over. Yeah.
हाँ अभी बुढ़ापा आ गया ना, अब क्या ऑपरेशन करने का.
Dr. Vasudev Gadigune, we always listen to his talk on the forearm nailing, I think in most of the national conference as well. So today he has changed the yeah. So let us now hear his inner heart side. I think Binoti has to answer that question. गलने वाली रॉड कहाँ मिलेंगी? तो सर ही बताएंगे. सर सबसे ज्यादा कॉन्फ्रेंस को जाते रहते हैं, इंटरनेशनल कॉन्फ्रेंसेस.
So good morning to everybody. Respected Dr. Saxena, my teacher is here, and we must have treated thousands of the patients of forearm fracture in the government medical colleges. There is no issue, and it's not a debate. Dr. Binoti Madam is a great pediatrician in Science Medical College, and my son is a student of her, and I know. So I know her integrity about the subject, but it's just a cross view. It's not a debate. So we must understand the different perspective of both the views. That is a forearm fracture in children, and the fundamental fracture does not displace more than it is during the initial injury. Slight overriding or angulation remodels beautifully. Minor imperfection in X-ray does not affect the functional outcome, and implants are plaster. They only retain reduction in the position first achieved, and they don't do anything for the use. On the contrary, in a comparative study between the conservative and operative treatment in a children, the callus formation as well as the time to union is delayed in case of a internal fracture. So forearm fracture management essentially two approaches. The mechanistic carpenter's approach of a modern orthopedic surgeons all over the world, and other a biological gardener's approach of old timers like me, that we have to do something good for the patient. So fracture management in children, the mechanistic carpenter approach focuses more on anatomical alignment and aims at the perfection in radiological images. Everybody knows, and you want that radiological image is more important nowadays than your functional outcome. So this is the fracture both bone forearm in an 11-year-old girl operated and fixed by me, not other way, fixed by me. And look at the function, it's a perfect function. But at 13 years of age, the scar bothering her in spite of her full function. And she came to me repeatedly, sir, को कैसा मिटाया जाए? So I have no answer to this thing. And these are the things which happens after the plugging. As well as a keloid formation is a more common after even a nailing also if you insist at the radial side of the wrist. So the complications, this is the Journal of Pediatric Orthopedic, madam. This is 2013. Complications of fixation 14 to 17%. And these are all complications are listed. Infection, delayed union, non-union, prominence of hardware, loss of reduction, compartment syndrome, and last is the ugly scar. This is not my, and this is 11-year experience of operative management of a pediatric forearm fracture by a very renowned author. So why carpenter approach is so popular? It is because of with the commercial interest. Implant manufacturer, they imbibe on you that this is the best method. Ye nail aaya, wo nail aaya, as biogradable nail aaya. And these are the so many things. So newer population, they more go for this thing. And insurance companies, that is one of the most, this is the modifying effect on our practice. And vested interest ruined our intellect to indulge in a crime of operating innocent children for only radiological perfection rather than the patient benefits. So this is, if you do agree with me, please clap that this is only a radiological illusion, not a functional problem. So forearm fracture management, I strongly support the biological Gardner's approach, which on the other hand concentrates solely on the eventual functional outcome with less emphasis on the radiographs. So this is the Gardner's approach, though a difficult art to now convince you here in the hall. Non-operative fracture management produces surprisingly excellent result, avoiding the risk of anesthesia, surgery, metal in the body scar, and need for the second surgery to metal exit. Iatrogenic osteomyelitis with pouring pus I have seen with my own eyes, and repeated surgeries in failure, as you have seen the case that Patki madam has shown, and that is probably because of the nailing or a plating in a right forearm. So literature, the management of forearm fracture in the children, plea for conservatism, and that is a November 1919. He may be an old timer, but what he says, it's a plea. Treatment choice of a complete distal forearm fracture in 8 to 14 years of children. There is no clear evidence that a close reduction and percutaneous treatment outcome oversees. The close reduction and casting is recommended in the complete distal forearm fracture in a children 8 to 14 years of old. And that is nothing but the reputed journal of a pediatric journal. So this is an example. I will show you now all examples. A displaced radial fracture with a complete dorsal translation, radial shortening and overriding, recently treated with a close reduction and percutaneous finish, as you, Binoti madam said. A common justification for fixation is to avoid high frequency of redisplacement following close reduction and casting. Several articles are favoring percutaneous fitting to most reduction alignment. And so this is not a new thing. It is in the literature now. But you can see here, this is my own all cases. This can be treated by close method. Madam has given how to do a casting and 3-point fixation. This is manipulation. And you can see here there is some translation it's seen. They are all indices you know, and it is available in literature. So this is another a remodeling ability of a distal radius fracture in a fractured children. The study evaluated result of a 34 overriding distal radius fracture. And you can see how wonderfully this is my own case. After a 1 year, you just cannot see the fracture also. Another example, a 10-year-old Nalini, and you can see here there is some translation it's seen, and you can see a radiological and functional outcome within a 6 month of your follow-up, 7-month follow-up. Another example, apex anterior type in 8-year-old child, reduction 3-point mold, appropriate flexion, intraosseous mold, pronation or supination depending on the level of your fracture. Maintain the reduction in long arm cast, and just you see the 2 months follow-up. You just cannot recognize where the fracture is. In follow-up, the care of elbow cast, as you know, and repeated X-rays are not necessary. You just the check X-ray after 3 weeks, and if there is some displacement, there is a stickiness of the fracture, you just correct the angulation and forget about the radiology, and you will find a perfect answer to your question. This is another example, a 10 years old child, and this is the reduction fixation. And then another, a 9-year-old child. These are both brothers you can see here, and I have got the picture yesterday only. Chota or Bada Bhai. And you can see here how wonderfully after 15 years now, 13, after 5 years of follow-ups, you just cannot see where is the fracture. Another example, a 9-year-old child, Tanmay, reduction, cast, follow-up, and you can see here, you see the example in the post-operative period, and in the 3 months follow-up, you will see that this is one badly done. And you can see after 9 months, radiological and functional outcome. I must thank Neha that he has given me the topic. I collected the phone numbers of 45 children, and then I got near about 15 children to get a follow-up after 5 years, 6 years, 9 years. And one of the medical student also in the GMC Medical College, he had posted his X-ray study. So what is this? Younger the child, better is the remodeling. So another example, a alien mold treated by osteopath. After 6 weeks, he came to me and sir said, is there any correction needed? I advised surgery, refused my advice, and patient accepted the deformity, refused for further correction. And you can see here, rotational malalignment still persist and difficult to remodel, and you can see the functional outcome. So these are all radiological illusion. There is no value to the radiology and functional outcome, and I can show a innumerable example. There is still, but the patient, they go well. Another example, a 10-year-old Mayur, flexion type of a plastic deformation of ulna and DRU joint. Plastic deformation is very difficult to correct, and probably you have to refracture of that particular thing. But you can say with the corrected mold and an extension cast, not in flexion. In a flexion, extension cast, reduction, and 4 years follow-up, you can see where is the fracture. You can see that these are all examples. 13-year male, 6 years follow-up, complete remodeling. Intraosseous membrane of a forearm is a dynamic structure, and therefore just believe on nature. With the forces of the forearm fracture, flexion, extension, rotation, the bone takes its own shape, and that is, it has been proved beyond doubt that the forearm intraosseous membrane, there is a difference between the leg and the forearm. Forearm intraosseous membrane is a dynamic structure, and it's an elastic structure, though it is a rigid structure. So another example, and you can see a displaced fracture. Temptation to after, nature reduces the fracture slowly, and you can see a 7-month follow. Within 7, just observe for 7 months, and this is the recent X-ray, and you can see here a functional outcome. A 7-month follow-up, full function. There is some deformity is there. Always you will find that the ulna is deviated toward the radius side for some time because of a dynamic pull of the intraosseous membranes towards the other. But Remodel, another example, alien years old, 5 years of follow-up, radiological and functional outcome, such a beautiful lady, however you want to give a scar. Recommendation on literature regarding acceptable alignment in forearm, it is all given in the books, and they have said that up to 30% of this angulation can be accepted. Just wait for some time, and then in general observation, some of the terminal range may be lost, especially supination and pronation. But the majority work which can be performed without full supination over the time, they compensate. And I have a very beautiful video, which is not because lack of constraint. I will show you how they compensate. They compensate like this in the elbow and shoulder. And I have a beautiful video of this thing. And no work requires a full supination, though it is said in the literature. तुम्ही supination मध्ये कोणतंच काम करत नाही. भगवान का प्रसाद लेने के लिए सिर्फ करना पड़ता, that's all, and that's all. Otherwise, no work is required for this thing, and therefore full supination is not required for the any routine activity of this. So dumbbell भी आप ऐसे ही करोगे in full supination. So remodeling potential is there, and you know all these things where you can be near the epiphysis, remodeling better. And last is the bayonet opposition will remodel it. So don't go on X-ray, but only one thing in management of the forearm fracture is do not discuss post-operative X-ray with patient's relative. That is most important. Reassure anxious parents by sharing remodel X-ray and functional result of conservative treatment. Second, angulation less than 30 degrees shall remodel in a year, and all deformities of more than less than 30 will disappear within 3 to 5 years. Occasionally, more than 30-degree angulation and rotator may require osteotomy. So complications of operative treatment is 15 to 17%, whereas in a conservative treatment, probably rotational deformity is in 7%. So if the patient is not accepting this thing, you just do a rotational osteotomy for a simple reason and avoid the surgery of each and every innocent child. So take home measures. Treat the patient with a biological method. Results of pins, wires, stains, etc. are good to read in books and journals. Best study results of conservation in a child is always superior to the best result of surgery. Thank you, madam. I respect your integrity about your subject, but still I have to say Neha has requested me to give. Probably I also. Thank you very much.
Thank you, sir. So again, the audience has the same question. So फिर करना क्या exactly?
Karna.
So what I mean, this was one of the question which was asked by.
दिखाओ. This is.
Right. So in fact, this was a question asked by the most of the senior authors from India when most of the Germans who have invented Binoti must be there at workshop what was conducted, and it was an honest question asked to them that what you would recommend. What you would recommend. So the most of the authors they agree that till 11 years they may not go for the surgery. That was the answer given by one of the senior most person who has invented this tense technique for the forearms. And beyond 11 to 12 years, I think it is a choice you have to give to the patients. If they are ready to accept the minimal angulation and wait for remodeling, it is fine. If they are not, in that case, the mini-invasive technique, what Binoti has said, it works beautifully because less scar. And if you are really good in technique, it doesn't require a good orthopedic surgeon. I think it is not very difficult for them. That was a consensus.
What about the radiation? Because when the periosteum is intact, and there is some translation 25 days. I have gone through all these things, and it's very difficult to reduce the fracture by close means, and it is very easy to say that you pass a nail. I have personally witnessed one of the finest orthopedic surgeon of pediatric surgeon from Mumbai for a surgical demonstration of a closed forearm nailing, and he struggled for 3 hours in the Shyam Medical College only. I was one of the witness. No, it was in the Cooper Hospital. And then ultimately he did the open reduction. And I was the witness. of a nailing course.
So there are many points for debates, and that is why you and Binoti are here. So,
Just couple of, because we are running short of time.
Yeah.
One or two things, that distal radius is totally different than forearm shaft. So you cannot compare. Amount of remodeling is very, very high in distal radius because it's the main growing physis and you can accept more. So a couple of SIRS cases were distal radius. There you are not going for any nail or anything. Secondly, the technique matters. What list of complications even I showed. But there are certain tips, like you don't use very thick nail because thick nail will distract the fracture site. So you use a thinner nail which will give stability as well as elasticity. Secondly, you identify an unstable fracture pattern. I'm not saying there is no plaster treatment. Plaster treatment still is the first choice. We don't want to subject unnecessarily, even though it's a small scar. But as I said, there are certain cases, certain indications where loss of reduction is bound to happen. You cannot call them at 3 weeks. You call them at 1 week. Suppose there is loss of reduction just about 5 degrees in one plane, you can wedge them. You can do cast wedging and correct the remaining angulation. But if the child is old, say 10 or 11 years and more, and if you have an unstable fracture pattern to start with, like say both displays, a segmental one, it's very difficult to maintain in cast. And we can't have all these indices. We never measure all these indices. But a thick padding, bogging, I think Viraj will agree that, follow-up and maintenance of that plaster is very difficult.
Yes, no doubt.
So in a
about it.
judicial cases where it is an indicated thing, I think you do follow the technique, follow the tips and have a good outcome. There are people who are in sports activity, they require catching ball, there is a paper by Vellon where they have studied some activities. They have just found out how much rotation you required for each activity. Gone are the days where you just do, we can compensate. You can very well compensate by shoulder in case of upper limb. But the amount of demanding children, they want to get involved in all these things, want to give them the first choice, ultimately, and that choice. I think, as Viraj said, put up pros and cons and let them decide.
In fact,
So
Not always conservative, not always nailing.
Yeah,
It
yeah.
is either ways as per indication.
I agree with you, madam. And these are the eye indications which I have shown here. Montage and Galegia fracture in children, they are very difficult to maintain and reduce also. Requires an open injuries. And you can see here, I do majority of the cases by nailing also. But such a displaced fracture cannot be reduced and do a close nailing. And I have a series of close nailing of a forearm fracture by screw intramedullary, probably more than 50 cases. So I do operate. But majority, I say, can be treated by a conservative treatment. So this is the, thank you very much, madam. And I feel that there are both the methods stands, but it is the difficult, not a difficult decision, but 12 to 14 year is the decision making is there. Up to 12 years, I probably majority can be treated, or 12 to 14 years, you may opt for a surgery because they have to go to the school early and so many other things. And probably they may not wait for so much remodeling because remodeling potential in girl after 40 is very little, or male it may be possible. So I do agree that 12 to 14 years, it's a borderline period, we have to take the decision. Yes.
Even you can even judge which are the fractures which may have the which are the children which may go for the refractures, because forearm bone again is known for the refractures. All of must be agreeing with this. Gadigoni sir, one question for the benefit of the audience: how would you control the mal rotation when you're giving the cast? You are
That
not
is already actually proximal, you give supination, middle, mid-prone, and for this is how it is. This is described when we apply the cast in the same fashion. In spite of that, some rotational malalignment may occur, which is though it is said that it is 7 to 8 degrees acceptable. But that don't think that the perfection in a angle and everything will be done by closed methods. But during the course of time, it gets remodeled, but not more than 10 degree of your this rotational malalignment. So you have to be very particular, not in angulation, but for a rotational.
Thank you, sir. I
Thank
think
you.
we'll move on to the next. Conduct, sir, you want to ask something?
One question, if you
Yes, sir.
permit.
Yeah.
So, Gadigone sir, if everything remodels, why there is a procedure of manipulation under general anesthesia?
No, everything doesn't remodel. There is a criteria are there. If it is 10 degree, 20 degree, 30 degree. Suppose if I have to do something, so in 10 degree I may accept it. But it is more than 10 degree, though it takes around 5 years, I will not wait for, because that boy will also go from one place to other place. So probably after more than 10 degree, I will subject him for remanipulation. Actually, 3 weeks. Actually, we are not going to change this traction, and we are just changing the angulation. चालेल ना, परंतु मी 3 आठवड्यांनी करतो.
So we'll put the next debate between Bhavukar sir and Gauri sir later. Thank you. Yeah. So I declare both are winners, Gauri sir and Binoti, because both are excellent in their subject. Thank you.
Thank you very much. Thank you very much, speakers and our chairperson, Dr. Singade sir. So we'll move on to our next session, which is a practically useful tips. And the chairpersons for this session are Dr. R.M. Chandak sir, renowned orthopedic surgeon and a very practical person. So and our second chairperson is Dr. Anil Masan sir. So please, sir.
So thank you, Neha, for this opportunity. And now we move on to the next session, which is very interesting. And may I invite Dr. Chasanal Rathod for a talk on practical points from birth to adolescents in a CTEV.
Thank you, everyone. And it has been a great session since morning. And coming to the last part here, CTEV, it's a very common thing. The first thing we often learn as ortho resident. And when I first joined ortho residency, I had told Patun sir and Badole sir that I want to become a pediatric ortho. So what in either of the unit, when there was a clubfoot child, they would send it to me. Isko pediatric karna hai, isko bhej do. So today I'll not talk about the basics or the casting techniques or the principles, but largely I would like to talk about what basic practical tips to be used in different types of cases, particularly the nomenclatures like a relapse and partially treated, a recurrence, a secondary club feet, and what tips to use in such things, such particular terminologies. So it's about from birth to adolescent, but quickly I'll start with before birth. So many a times we come across parents who come antenatally with a report saying that the child, they have been diagnosed having a club feet, and they have a report which shows this deformed feet. It's of course a very sensitive time for the couple and the extended family. The younger couples nowadays have no patience at all to continue such pregnancy. And I have had many such couples who say that the world is very competitive and we don't want a disabled child. And it is actually our responsibility to prepare them and help them continue with that pregnancy and help the mother alleviate all the anxiety which she is going through. What I would do is apart from helping with all the material, helping them connect with other mothers. So I have a support group which every clubfoot mother gets added, and then the other mothers try to help her through it. So apart from doing all this thing, what is one of the most important thing which we should do is we should talk to the sonologist and look for 2 things in follow-up scans or a repeat scan. One is that there should be adequate knee movements during the dynamic antenatal sono or whatever scanning they are doing. Either they are doing a 3D scan or 4D scans. And if there is no knee movements, then of course it is much more complex club feet where it's an arthrogrypotic multiplex complex thing. And we might need to explain the mother that there could be knee, hip, upper extremity involvement, and the child may not be an ambulatory child also. Apart from what a simple idiopathic clubfoot would be like, where the child would have a almost near normal corrected feet within 4 to 6 weeks or within 2 months after birth. And second is subsequent calculation of length of tibia and foot size. and also particularly if we are suspecting some hemimalias. And I'll quickly show you one case that why the second point is very important. I myself make it a point to get a second scan from a different sonologist done, talk to them and clear both the points before having antenatal discussion with the parents and putting down on the paper that why they shouldn't undergo an MTP for that. Because the families are really very keen on getting that done, because that's much more easier than dealing with a child with the problems. So this was one of the case. The mother came to me at 20 weeks. And if you see the lower picture here, we can actually see a club feet here, the feet. And the report also said it was a club feet. And very confidently, like all other club feet antenatal counseling, I explained these parents, it's all going to be fine. And when the child was born, they shared this picture with me. And they were very upset about the whole thing, that there was no feet. There was just a distal stump of the leg. And of course, I had nothing to do based on the report and the subsequent scans. I explained them, but yes, we could certainly land up in such cases at times. So that's why the primary two things are important, that we explain them that this could happen. And what I suspected looking at the previous scan, that probably the child had an amniotic band, and which led to auto amputation of the foot. So thick streeter's dysplasia or amniotic band could have caused this, because the child had a raw wound at birth. And this is much later, which they sent me at a follow-up when it was healing. But now, like, this is something which we just can't discuss with the parents, and they are really disheartened about the whole thing. So based on this, I always think it's important to discuss these 2 points, that there is no AMC, and then the foot and the TBR are growing well. It's not a hemimalia or a terminal absence of feet. So this is something which should be thought before birth, before the CTV is actually seen by us. And of course, with the advent of Ponseti treatment since the early 40s, the whole treatment changed from the extensive PMSTRs, which we used to do, to complete conservative treatment. And we know that right from birth till kids as old as 11 and 12 can be treated with Ponseti. And it's a widely accepted treatment now all around the world in any sort of setup. There are not only doctors, but even trained nurses in remote areas who are capable of doing Ponseti casts for children in different countries. And there has to be a fixed protocol, and there's a fixed protocol, what needs to be done. Everything is well defined. But what happens when the children don't come under that protocol, or what happens if somebody doesn't treat them as per protocol? And then what is the thing which we should do? So this is a child who came to me at 1 year, had very random cast. Now this is in Mumbai, in a city, Mumbai. And they had cast at intervals at 1 month, then at 15 days, 20 days. They were not following the Ponseti at all. I don't know which method it was. And then after a couple of casts, they were left without tenotomy, saying that it's going to be fine. Just wear CTV shoes, which again, no more we prescribe. CTV shoes are not part of Ponseti protocol again. So at this point, it is important that there could be various options, that we start casting this child, do a tenotomy, or do a tenotomy and then further give cast, because now the child is older and the deformities might be little rigid. And of course, the last one is not very much needed, but people can still think the way they want. What I suggest, based on all literature, is whenever there is such a case which has been half left, or which has not been treated or properly, or which has not followed the Ponseti protocol, we start it from cast 1. It has to be restarted. We don't start it midway, or we don't do tenotomy and then cast. So it has to be started just like we would be treating a virgin club feet, and do the same casting techniques. If the child is older, use pedicloral. If the child is still not manageable, do it under short GA, and subsequent casts, and then tenotomy, and same bracing. Of course, these kids might need much more bracing, more than 4 years as per what the protocol. And they might also need a walking AFO, because they have lost that daytime bracing time, which otherwise the kids would have worn for 23 hours, 20 hours. Here, the kid might need a AFO with a slight CTV correction in it. So that's what we would do when kids come like half-heartedly treated. This is the same child at 3 years follow-up. And yes, I do ask the parents to get this lighted shoes, because anytime if they feel that the heel is going up It's a quick indicator for the parents to come back that the equinus is having a recurrence. And there have been studies with newer footwears, the braces, where there are sensors which pick up the data, or they send data to the center, and data can be evaluated if the parents are putting the splint well or not. Now that requires a lot of work. Instead, this is very easy. The mother can easily pick up, and these shoes are fancy for the kids as well. So this is the same child, and it should be, this is what is from the case. Second is, we often see rigid and neglected and older children, and these have never been treated. Unlike the first child, these kids have never been treated. And when I came here, I had to certainly acknowledge Viras sir for his work in these type of cases, and he has a wonderful series already published of kids from remote area who have no access to healthcare, which he has been treating by going to those areas and providing a one-stage, simple, easy solution for kids from this low socioeconomic strata. And I think this involves a simple soft tissue procedure like a posterior release, a plantar fasciotomy release, and a dorsal wedge resection osteotomy. So this is what sir has already published, and if I was here, I really need to acknowledge this. So I have put a case specially for him here. And yes, we also do come across similar cases who travel and come to us, and the same approach is done for rigid, neglected children, and they do well. So, okay. So this is the child which was pre-op, treated with soft tissue release and a dorsal wedge resection, and this is sir's follow-up. And I'll show a couple of more follow-ups if needed. So like I said, it's a very good, cost-effective, single-stage techniques, gives the same correction, near normal, pain-free feet, which has not needed the need of fusion. So the subtalar joint is kind of spared here with minimum complications, like no much of pressure on the medial side while correction. So simple lateral shortening osteotomy would still have little pressure on the medial side. So this is very helpful there, particularly in older children. So now, for particularly which sir showed, this was a 5-year-old child where he has performed the dorsal wedge resection. And now this is the same child, 10-year-old, rigid and neglected, never treated anything. But the child has caudal regression syndrome. So he has much more severe feet. Here at least we are able to see like a simple lazy J kind of thing. But here it's like totally a severe L deformity, which we see here. So this child I have treated with similar soft tissue release. And these are the kids where there's a role of fixator rather than just doing an osteotomy, because here the osteotomy would not correct and still cause maybe some neurovascular compromise. So a gradual correction with prior TL, this has undergone a TL lengthening, and as it was a caudal regression, I added a tip post lengthening also. FHL and FDL tenotomies, a plantar fasciotomy, and then the JES for gradual correction to avoid any skin problems or even the neurovascular issues. So that was about rigid and neglected ones. But now, in spite of all the trainings and all corrections and everything better, we could still see kids which have relapse or recurrence. Relapse or recurrence are the ones who have undergone entire treatment and they have got corrected. And now we start seeing some component coming back. The first component to come back is always equinus, followed by adduction or the supination. And that can further be divided, like if the supination or the forefoot adduction is static or is it dynamic. And based on that, the further treatment could be planned. So the main cause, 80% of the time, the relapse is because of non-compliance of the splint. And the various government or the NGO related programs, they focus the cure programs or the miracle foot fit programs. They focus more on compliance with bracing, and they have social workers who kind of visit the family and check if the parents are actually putting the brace or not. Apart from that, we could have the chip-based brace, which also give us the data. But let's look at this now. Suppose, this was the child treated. So this was a child 6 years old, once treated with Ponseti at a younger age of 1 to 3 months, then again had a recurrence. Again, a retinotomy and cast was done. And at 6 years, now the child walks with a dynamic supination, and of course there's an equinus. So this is a very simple case. Once there is a dynamic supination, and if the lateral border is straight, then we can simply go with the tibialis anterior transfer and it works well. So this is the child post tibialis anterior transfer, and then they again undergo the same bracing protocol. No matter if it's a recurrence, it's still important that to prevent a recurrence again, we need to brace them as much as possible, particularly the nighttime bracing. Second point of the same recurrence or relapse where the deformity is now static. If just dynamic, then the tendon transfer is the help, which is the go-to solution. But if there is a lateral border which is not straight, and also there is a supination which is static as well as dynamic, then this would need a lateral column shortening. This is not as severe as what severe feats which Virat sir has described, the type 3 and 4. And here a simple cuboid osteotomy is sufficient to correct. So a small lateral column shortening is what an option could be for younger child, secondary club feet. So this child is an arthrogrypotic child, and with just a simple lateral column shortening. So just a cuboid shortening osteotomy is done, fixed with K-wire, and this child is done well. So if we look at him from side, he walks on the lateral border with equinus, and he's a child with AMC. This is the pre-op, and that's the post-op. So because of AMC, still his abductors are weak and he has a lot of issue in walking. And that's how the secondary club feet. So secondary club feet which come from any neuromuscular problem or a syndrome problem have a higher chances of relapse and recurrence. And if they are rigid, then of course we are going to do a bony procedure. If they are just dynamic, always a soft tissue procedure is enough. And if they are more severe, then probably more extensive osteotomies or a fixator might be needed. And last but not the least, one of the most important components in club feet is the tibial torsion. We always studied that we look at the feet, but one of the component is the tibial intorsion. And in older children or children with secondary problems, myelomeningocele or any syndrome, they have a lot of tibial intorsion. So if we look at this child was previously treated for the club feet. He has undergone an osteotomy for the femur, which was the derotation osteotomy done. And now he got a recurrence, and there's a dynamic supination and the tibia is in intorsion. So if we look at it, how I picked it's a dynamic supination. I have done an additional video of his with the orthosis. And if the AFO corrects the supination and if the feet become straight, that means it's dynamic. But if the AFO is also turning inside, that means it's coming from the tibia. And here, and also the examination of thigh foot angle and checking for the intorsion. So along with all the soft tissue, the tibialis anterior transfer, the equinus correction, or tibialis derotation supramalleolar osteotomy helps in these kids. And in an idiopathic child, of course, this remodels. But in a secondary child where there is MMC or a syndrome, it has a very less potential to remodel. And doing these osteotomies early gets us to a very good splintable feet, correctable feet, and almost a very good walking. So this is the supramalleolar tibial osteotomy for him. So this is the child, which was, that's the pre-op, and this is the post-op. And what I mentioned about the splint, so when he walks with the splint, we still notice the feet is inward. So if it's just a dynamic problem, the splint will correct. But the skeletal problem, the splint will also go inward along with the deformity. So to conclude, I would say that yes, Ponseti protocol is the standard protocol. We need to follow all the steps and the way they are described. And anything which differs in that is going to certainly lead us with iatrogenic club feet, which we are creating, which needs to be again treated just like the Ponseti protocol. So we don't look at it as a different deformity and start correcting in a different manner. Casting in an idiopathic one helps up to age 12. And non-compliance with bracing is the major problem of relapse. And all the relapse cases, we could treat them based on all the cases which we have seen. And I think the secondary club feet, which I mentioned, yes, they are little different than idiopathic club feet. They have lot of muscle imbalance and the relapse rate is higher. They need different orthosis like a AFO, or the foot abduction brace is also different with little less angles, and that's how they differ. So these are some of the practical tips which vary from club feet, amongst the club feet from patient to patient, and an a la carte approach certainly helps us to get these feet pain-free and very supple, normal-looking feet. That's it. Thank you.
Thank you, Chasanal, for giving practical tips on counseling and methods of very effective and innovative ensuring the compliance with the braces. Thank you so much.
Thank you, sir.
With that, we move on to the next talk on practical tips. And
Chansal ma'am, I'd like to ask you, your child on day 1 of CTV. So how long do you like to observe that patient for braces and follow-up? The age of 12? You've seen the child on day 1, CTV. So how long do you tell the parents to come to you? 4 years. Years. So we have the next speaker, Dr. Sharmila Tulpule. She's going to talk on a newer approach of management for early osteoarthritis.
so now we have some practical tips of managing osteoarthritis. All of us have those patients, and patient is not responding. Taken all A to Z of analgesics, and you converted them from Voveran to Brufen and everything. Let us see something like gold-induced autologous serum therapy in osteoarthritis. Let us see
Hi.
how the works.
So I'm going to be a little fast because we are running short of time. So, right, I don't go into the details of osteoarthritis, you've already said. It's extremely common in females in India, is unbelievable statistics. 70% of 65-year plus show positive radiological evidence. 45% of them are symptomatic. And we follow KL classification, though it doesn't actually clinically correlate. So more of clinical rather than radiological, I would say always. In the pathophysiology oscillating between arthrosis to arthritis to arthrosis, and again now we know that it is arthritis, wherein the anabolic factors are, it's all imbalance between anabolic and catabolic factors. So we've exhausted our options of conservative, and before surgery, we want something to be done. Regenerative options I have already discussed in the last lecture. So we discussed goldic therapy. Gold as a medicine, I'm not sure whether you remember rheumatoid arthritis, that was the gold standard till 1985, I guess. Initially, we used to be very much aware of that and it is to be used. And in 1985, methotrexate came and then this got all replaced. By that time, we knew that gold is extremely effective for arthritis, rheumatoid arthritis, but it has its toxic effects. And so the concept of removing the toxic effects, so you take the blood outside the body, make it react with gold salts, and then you filter the gold out. So what remains is a super serum, we call it. With its anti-inflammatory and regenerative property, it can be very effectively used in many inflammatory as well as degenerative conditions. So this is the best solution using gold extracorporally. So goldic stands for gold-induced cytokine therapy, in which specially designed gold particles, almost nanoparticle size, are used. And so the serum is very rich in cytokines. This is the analysis of the serum which was done. So gelsolin is the key factor. Gelsolin is in high percentage in this serum. It is almost 10 times higher. There are other factors also which are very, very rich. All the cytokines and growth factors, but cytokines are higher. And the main, I would say, is granulocyte colony stimulating factor and hemopoietic stem cell growth factor. Now, gelsolin in osteoarthritis, what we realize that normally if there is osteoarthritis and you take blood and measure gelsolin, normally you find it low than even a normal person. And so this is very important. It's an acting binding protein. I won't go into the details, but those cytokines basically help to even activate local stem cells. Okay, so other than the local anti-inflammatory effects, it is the stem cell effect also happening, and that is what makes it completely different from a PRP. It also helps to differentiate local stem cells. Gelsolin, which is in very high quantities, has multiple effects in the body, right from the neuronal system to cardiac system to skeletal system to hemopoietic system. It has also anti-aging properties. Initially, how it was discovered, he simply injected into, Dr. Ulrich, he injected it into limp horses, okay? And they started running in 15 days time. And that's how he realized that, oh, this is something different working. And that's how, he started doing human trials. This was back in 2000. And then there are these many studies that initially were published for osteoarthritis, knee, digits, other osteoarthritis, tendinosis, disc herniation. We just had another paper published for disc herniation, bursitis and other. This was a 4-year-old study, 4-year-old follow-up we had done. This was, I guess, 4 years back. So now it is almost 8 years. But just look at the pattern. Okay, with time, it gets improved. So it's not that, the initial spike is there and it goes down. No, it is like with time, it is getting improved. And the pain score is coming down at 4 years, it is less than even 2 years. These were multiple papers that even I was part of, and we published intra-articular cytokines initially for lots of things. Okay, this was anti-inflammatory effects, and even intravenous Goldic has been used. It's very safe. It's just used for rheumatoid arthritis as well as long COVID. That also one of the researches that we published very recently. So now we know that there are positive results in lumbar disc disease, tendinopathies, osteoarthritis early grade, and I'll discuss my experience in knee osteoarthritis. It's mainly, I have been using it in peripheral joint, primarily knee osteoarthritis, sports injuries, shoulder lesions, frozen shoulders, as well as rotator cuff, tendinopathies, and IV Goldic as well. It's an ongoing study right now. We have not published it. This is a 2-year follow-up. So total, there were 82 knees being done. 7 were grade 2, very early. 34 were grade 3. And surprisingly, 43 were grade 4. It is not grade 4 plus. That means it's not subluxated, but it is near to bone and bone. Near, not exactly bone and bone. The protocols were failed conservative treatment, that is first, and all stage 4 had been advised total knee replacement, which they had refused. And that's how they landed up with this treatment. So I'll just give a short overview. So this is how it is done. We take the blood out. It is 40 ml blood per joint. So this is for 2 joints, obviously. It is incubated. So these syringes are the Goldic syringes, which are lined by gold nanoparticles. With the gold nanoparticles, they are incubated at 37 degrees for 24 hours. After which it is centrifuged. This is how it looks after centrifuge. And then it is, this is how it is filtered. This is a 0.22 micron filter. So ultimately it is filtered. So it filters out gold nanoparticles as well as RBCs, WBCs and platelets. So this is the clear Goldic serum that And this is how it looks. We get out of 40 ml, we'll get 4 syringes of around between 4 to 6 ml of ready serum. This is stored at minus 22 degrees after this, and we give it periodically over. Our protocol is for 2 weeks. We can maximally give it till 8 weeks in case patient is traveling or something. So treated with 4 consecutive Goldic injections over 2 weeks. All were administered under ultrasound control. I'm again and again stressing that. Assessment done with VAS and WOMAC scores, and response also assessed with the same scores at 3 months, 6 months, 1 year, and every year afterwards. No patient had any major adverse effect. Out of these, 6 patients had absolutely no pain relief, which was all grade 4. Grade 2, all of them had 100% relief. Grade 3, they had 91% pain relief at 2 years, which remained. Even now we are following it up and it's doing very, very good. Grade 4, now that's very interesting. 37 of them had a slow onset of relief. It took about 4 months for them to say that, yes, they're feeling better. Went on to improve to a very significant relief between 75 to 85% till 1 year. And it is still improving. So this is how it looked, the pain improvement chart. The earliest to improve was pain at night. So those who had were in extreme pain at night, that improved first. Last to improve was climbing down the stairs. So obviously the patellar component was the last to improve. It took about 6 months for them to improve. Patients with grade 4 osteoarthritis with various deformities also were there. They improved, they had noticeable improvement in gait and speed of walking. Grade 4 ONEs with restricted range of motion, that did not improve much. No patient needed to take any NSAIDs after the therapy till date. So that was a big plus, okay, that if they are on NSAIDs continuously, at least that is, they are off NSAIDs. So this worked well. This is working well for osteoarthritis. Though the follow-up is short right now, 2 years, it looks effective for pain relief in osteoarthritis. It gave excellent pain relief in grade 3. As for advanced grade 4, it gave significant pain relief and it improved the quality of life definitely. It could therefore be definitely considered to avoid postpone replacement in patients who are not wanting the surgical option or wanting to delay the surgery. These are some of other indications that we had tried our Goldic. This was a professional golfer. She had chronic Achilles tendinitis for more than 3 years. She had to give up her golf completely, and she had tried everything, whatever was, and she was about to going for surgery. We started the treatment. This is a 1 year follow-up picture. This is a MRI picture in which it completely recovered in 1 year's time. This is a disc prolapse that was treated, who was in very bad pain when he came, and with Goldic therapy, again, 4 epidural sessions, and this is 3 months follow-up. Cervical, C5-6 disc prolapse. This was my friend actually, 47-year-old, had very bad cervical radiculopathy, refused to do surgery. It was very strongly advised. We had advised him surgery and he refused, and he said, no, let me try this, and it wonderfully recovered. This was rotator cuff tear, 2-year follow-up showing complete healing. It wasn't, mind you, this is not a complete tear, it was a partial tear. Again, Achilles tendinopathy, showing very good relief. Knee MRI, I don't have very good pictures of knee MRI, but it started showing little bit remodeling here of the articular cartilage. This is at 2 years, the thickness of cartilage coming back. It takes really long time for actually, pick up MRI picture of cartilage thickness coming back. It takes time. We generally see it at 3 years. Not everybody, but we do see it. I think around 30 to 40% patients have shown remodeling. Again, this was an osteochondral break there, which healed completely.
So can you summarize, ma'am?
Yeah. Advantages over PRP. Goldic is acellular, no anticoagulant needs to be added, has uniform protocol. That's very important. So more defined results. Post-treatment period is not stormy. And effects are very much longer lasting than PRP. So this could be an effective solution to delay the disease progression. More studies are needed, no doubt. Thank you.
Well, thank you. Ma'am, I'd like to ask you,
Yeah.
these are, of course, the patients who come to you are patients who are
Yes. At least grade 4 ones.
but of course, all these treatments are very, very expensive.
They are.
So how do you convince them that they need
No.
ultimately follow up for 2 years also?
Okay.
I want you to share that experience.
Yeah. So it's not we who convince, it's they who demand. It's as simple as that. If they are saying that they don't want surgery, I give them options. No, we don't tell them that this is going to work. So we do tell them. So right now, okay, with my experience, the failure rate has been around 10 to 11%. It's that low. So if they have, okay, 90%, there is a chance that this is going to work. What we tell, this is my dialogue to them. Maximum you will lose is only money. That's it.
Right.
No, it's not covered under insurance at all.
Injection.
It is the kit cost itself is around ₹1,00,000, 90,000. So you charge whatever you want to around after that.
So I think Saxena sir is here with us for last 45, 50 years. Sir is in practice and seen osteoarthritis. I want you to share your experience on.
Yeah, the osteoarthritis, we should not be taken purely as a mechanical thing.
Absolutely. That's what
So
I mean.
many
The whole
factors. You must have seen the bad X-rays and symptoms are minimum. You must have seen very good X-rays and the symptoms are there.
yeah. So many times it happens that a grade 4 plus, I just refuse that I'm not going to entertain this, and they beg and they say that no, we don't want surgery. If you don't treat, we are just going to go home.
Yeah.
And then you inject with least hope, and they do extremely well. So we've not understood osteoarthritis. That's what I realized actually at
Yes,
the end.
yes. Basically, it's an inflammatory disease.
Absolutely.
And all these body fluid have an anti-inflammatory property.
Yeah.
That is working everywhere.
Yeah.
Yes.
But
In
with
the-
gold induction, what we have seen that gelsolin, what is there, that's the key, which is, it's not only helping osteoarthritis, beautiful results in rheumatoid arthritis, psoriatic
same
spondyloarthritis,
things.
ankylosing. It's like unbelievable,
Same thing.
the results.
Symptoms are mainly because of the inflammation which
Yeah,
is there. in
that's
that
why.
part.
And it's quite long term.
I attended a conference of regenerative medicine in Berlin, where the chairman of the conference committee, he himself was using these methods. And he said when he had a distal end fracture radius, he asked the nursing staff to take out his blood and inject over there about 10 cc's. And he said, I did not take any plaster or anything. I became all right. Now, imagine a person of that cadre also promoting regenerating medicine.
So basically, it is like, you don't claim that this is going to work. That's the fundamental thing. It is no, it's like, it's biological. It acts at cellular level. You cannot predict. This is not mathematics. This is not mechanical. So it will be, the results are going to be variable. With time, you realize that who's going to respond, who has more chance of responding and who has less chance of responding. And that's how you balance it out actually.
Yeah. I think we are gradually going to the era where there are minimum side effects of the things which are being.
Yep.
And when you use the patient's own fluid, serum, or the blood, then these chances of side effects are minimal. Otherwise, with the steroids, with the other kind of solutions, chances of side effects.
Thank you so much.
So now I request Binoti ma'am for her talk on femoral shaft fractures.
Let me assure you it's going to be very quick. No innovations, no debates. So we are going to straight bang on case-based practical approach. What do you choose for what fractures? So it's again a very common fracture. You see them right from neonates till adolescents. They all are different. So the treatment is also going to be different. You have all these options. You treat them by just Paulic harness. You have spica cast. You have tense nail again. You have plates. You have fixators. So what's the right treatment? There are certain factors which you have to take into account while deciding what is the treatment. First is age of the patient. What's the fracture pattern? What's the site of fracture, whether it is proximal third, middle third, or distal third, whether it's an open or closed fracture, and also the weight of the child. When in adults, we never think about weight. Here we are going to talk about that also, and then some minor factors. So we'll go case wise. So this is a 2-day-old child who had a birth trauma. While delivering, there was a difficult delivery and landed up with a femur shaft fracture. So what would be the treatment? Well, the surgeon was not aware. He had never seen such a child, and he thought child and 2-day-old, so it will unite. So he just gave a big thick slab. Obviously, that slab was ending at the fracture site. So the fracture was still moving. The child was painful. He increased the width of the slab. Look at the slab width. Again, it was not working. Child was crying. He tried to extend till the abdomen, thinking that the fracture will stay in place. But this was not the right treatment. And see what happened. The fracture did unite because it's a 2-day-old child. Nature is great, but with significant malunion. So this is a group which is infants from 0 to 6 months. These are very, very stable fractures because they have very thick periosteum. But apart from birth trauma, if you see a child, this age child with fracture, always look for abuse because these are non-walking child. They cannot fracture just like that. Or you think for underlying metabolic abnormality or any pathological fracture. The treatment for choice for this age group is a very simple Paulic harness, which is going to give rest to the joint in the desirable position, and this unite beautifully. Only some rare cases where you have very unstable fracture or if there is excessive shortening or excessive angulation, you're going to put them in spica cast. Otherwise, just with Paulic harness, see how beautifully the fracture unites and remodels in just 6 months' time. Such a markedly angulated fracture is united just with Paulic harness. Coming to second case, this is now little older child, a 4-year-old child with middle third oblique fracture. What should be the treatment for this? Now again, here you cannot put them in Paulic harness because these are little bigger children. So this is a group of preschool children, which is between 6 months and 6 years. And for them, spica cast is the best treatment for an isolated shaft femur fracture. The problem is whether you give day 1 spica or you give preliminary traction and then spica. That is the treatment decision which is to be made. So for that, what is described is something called as Thomas's telescope test. So under anesthesia, when you telescope the fracture, you give axial compression and see how much is the overlap of the fragment. If it is more than 2 centimeter, it is advisable that you give preliminary few days of traction in order to get the length. And then you convert them after 2 to 3 weeks into spica cast. So after that, you give them 1.5 spica. And if it's a very, very subtle and stable fracture, sometimes you can even give a walking spica where the other limb is free and the child can immediately start walking for a low velocity and stable fracture. Some technical tips for giving a spica in children: you must have adequate padding because you know they are going to go through a lot of bony prominences. The position is important based on the fracture fragment, but roughly it is about 30 to 60 degrees of hip and knee flexion, about 30-40 degrees of hip abduction, and 15 to 30 degrees of external rotation. You take weekly x-rays. If there is any angulation, loss of reduction, you can wedge them within if they come early. And this is the acceptable alignment for different age group. So this is the child which is beautifully united after preliminary traction and spica cast. Coming to little older child, now 7-year-old, in middle third transverse fracture. These are school-going children, cannot be managed in spica. So for these patients from 6 to 11 years, ESRS nailing is the best treatment. The ideal indication for tense nailing in children is a length stable fracture, which is going to be in mid 80% of the diaphysis, a non-comminuted fracture, and a thinner child, so weight less than 50 kg. These are the ones which can do beautifully with just tense nail. But if it is anywhere beyond this, that means if it is proximal third, distal third, or if it's a heavyweight child, then just tense nail may not suffice. You may have to either use a submuscular plate, or you have to use additional external fixator. So nail with external fixator, which is a hybrid. So I think I'll not go into the technical details. Many of you may have done, but all these things are to be taken care of. You must have an adequate size. You should bend them properly. Take care of the, not going ahead. Yeah, so you must have a good nail size, bending, then again avoiding the physis. You try both sides simultaneously, advance till the fracture site, and then go right till the greater trochanter and to the femur neck in order to have the right alignment. Coming to the last variety, which is the adolescent femur fracture, which are neither children nor adults. They have high velocity trauma. The size of the child, the weight of the child is more. Remodeling potential here is less. The acceptability is less. You can just accept about 5 degrees angulation in coronal and 10 degrees in sagittal plane. And they also have to go quickly back to their school or resume activities. So you require little more rigid fixation. So for these, the ideal ones are rigid locked intramedullary nail, which is a preferred implant in adolescents because it gives high union and allows for early weight bearing. But remember, the entry here is not like the adult interlocking nail. Because if you go through the tip of the trochanter, you remember there is a physis, trochanteric physis there, and if you arrest that, then the child can have coxa valga and shortening. So you avoid piriformis fossa, you avoid tip of the trochanter, and these are special lateral trochanteric entry interlocking nails, and you use small diameter again, prevent damage, any damage to the proximal insertion area. As an alternative to this type of nail, because which is not easily available, costly, you can use submuscular bridge plating. You have limited incisions, you maintain the periosteum, and you use long plate with few screws. Again, gives stable fixation and maintains the vascularity because you are going to put them submuscular and can have early union. External fixator is restricted when you have an open injury or very, very proximal or distal fracture, but it has its own set of complications like any other external fixator. But external fixator can be used, as I said, as a hybrid mechanism. Now, this is a very long oblique fracture. Just tense nail may not have a stable construct. So you do tense nail and supplement it for initial 3 weeks with external fixator. Once the fracture is gummy, you remove the external fixator, and then the child can be continued on brace. So to conclude, in femur shaft fracture, the right choice of treatment modality and correct execution of the technique are very important. For infants, it's Paulic harness. For 6 months to 6 years, it's hip spica. For 6 years to 12 or 5 to 11, you have tense nail or with or without external fixator, depending upon the type of fracture pattern. And in adolescents, either you use a special trochanteric entry interlocking nail or submuscular. Thank you so much. So this is the algorithm for any fracture. You assess all these factors and then decide what is the right treatment. This algorithm is there in our textbook. I, with some of 2 other doctors, have come out with a book on pediatric trauma, and this is part of that. Thank you so much.
Thank you, ma'am. That was wonderful summing up and practical tips on the management of fracture sharpness. Any questions? I think that was wonderful. Good. Tips were really.
So friends, we thought the women are going to be here and we are going to, we were very apprehensive, how is the session going to be? But even the lunch is delayed and you still have audience, seniors, juniors. So a big round of applause for all the women who've traveled all the way. And a big round of applause to our Mrs. Secretary Neha, who is brainchild and who's taking care of it.
Thank you.
So over to you. Thank you.
Thank you, sir. Secretary to secretary. Thank you very much, sir. So we'll quickly move on to our next session, which is a case presentation by our own VOS members. So chairperson for today's session is Dr. Apte, sir. And the first case is by Dr. Alok Umre, sir. Another chairperson is Dr. Alankar Ramteke, sir.
Unopened. Chopra. So, good afternoon, everyone. And I thank VOS and Dr. Neha for this opportunity to present a case. And I'm presenting a case of a 35-year-old male patient was diagnosed with a left hip arthritis secondary to AVN and was operated for a left hip total hip replacement. So these are the pre-op X-rays and a post-op X-ray only AP I have. We couldn't retrieve the lateral view. So seeing the immediate post-op, I would like to have the opinion of the house. Whether do you find anything different in the anything wrong or something? Whatever you would like to have opinion. Maybe I'll ask the chairperson, Dr. Alankar. See, this is we don't have PBH X-ray. This is the case operated elsewhere. Yeah, I agree. Yeah, I do agree. Okay. Okay. Yeah. 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 Yeah, I mean, if you can see the lesser trochanter at the level of ischial tuberosity here, and you can see now it is going. That is the only thing that I can find. Okay, that was the immediate post-op X-ray that we could retrieve. Anything about the cement? Anyone would like to comment on the cementing technique or something? We have I mean, the mantle is good. Distally, you can see around 1 inch cement, even proximally. It might be a bone restrictor, I suppose. Yeah. So, but yeah, yeah. I mean, a cementing technique has been done. That is all. Yeah. So, yeah, very true, sir. And now this is what he presented to us after around 12 years. Yeah. So he did very well with 12 years. He was pain free. And now he presented to us with a sudden onset of pain and inability to walk. And there is no history of fever, no history of trauma, fall, no significant any history which may land you in any particular diagnosis. And infection was ruled out. So anything we suspect with this history, what the patient might have got, it is involving the same hip, which I'm. Yeah. Okay. Hmm. Yeah, yeah, yeah. I'm not showing the X-rays. I'm just for the discussion's sake, I would like to. Okay. Any other opinion of the house that because if it is a polycide, it may be a slow and gradual history. Here pain ora. I mean, for months or weeks, he may come with this complaint. But it was a sudden onset pain, not able to walk in 1 week, and he was uh, having difficulty in. Yes, sir, very true. Stress fracture involving the shaft. Yes, sir, very true, sir. So we couldn't diagnose with the concerned history. We got the X-rays, and this is what we found. And this is after 12 years of pain-free period. Now the stem is fractured. So now again the next question is, why do stems fracture then? I mean, uh, very true. Yeah. Yes, sir. So very true. Yeah. Now, yeah. Financially, very true. Yeah, yeah. Okay. So just again burning this particular controversy and taking one step ahead, while going through the literature, every implant, every company has a failure record. Say it the best of companies and say it the worst of companies. I can quote from Chanley to Muller to whatever companies you can say, and I can give you the failure. Yeah, I agree. I agree. This is the Indian company. Say this is the Indian company. What people would like to say, this is the Indian company, though, so this failed. But literature says best of companies all across the world have a failure record of stems. So sorry. So the risk factors, we search the literature and cemented like hips after 4.5 years, cemented stems have a significant higher rate of breakage than a cementless stem. This is what one of the risk factors. But other risk factors were equally important, and these are the risk factors for failure which we all should know. It is male, relatively young patient, increased BMI, higher level of activities, stem positioning. I thought that valgus positioning is good, so it is also not good. It has been mentioned that valgus positioning is also equally responsible for a stress fracture. Undersized stem is also not good. Diphysial fixation, poor proximal bone support, that is absence of calcar, and modularity is a bad. I mean, what we all are using, including me, is modular stems. So it is also one of the risk factors for stem fractures and neck fractures. So now, next controversy, which Alankar very well quoted, that cemented and uncemented. So do only cemented fail or do only uncemented fail? Now that was my next point of concern. So why cemented stems fail? It is inadequate proximal stem cementing, overloading of the stem from the cantilever bending forces. What Apte sir had very truly said. Loosening of proximal stem and distal well fit stem. Gadigone sir mentioned about it. Absence of AP flanges which let the cement come out of the proximal part. Significant subsidence. Now the very important part is significant subsidence of stems. If it is small subsidence, it is acceptable. It is good for the patient and the stem. If it is significant, it is bad. Now, how do we differentiate this is significant and this is not significant? Now, matte surface stems are not now out of vogue. Very well polished stems and abnormal stresses. And one of the physics part was there. Stress was equal to moment upon the section modulus. That means the metallurgy of the cement, the stem material. And moment was force into the distance. How much cantilever effect, how much stem which is loose. The more the length of stem which is loose will cause more chances of fatigue failure. And now here, why uncemented fail? So if the fatigue fracture hydroxyapatite coating is more than 100 micrograms, it will fail. If it is less than 30 micrograms, it will fail. Unbonding of proximal stem and a good bonding distally will fail. Corrosion at head neck junction and stem sleeve interface. The stem sleeve interface for SROM. So SROM is one of the standard companies. I mean, belong to that. Mechanical motion, fretting at modular interface will lead to failure again. So both the stems fail, cemented or uncemented, Indian or imported. So this was the, if the video works, that was the painful part of the patient. Now here the next question is, should we now remove the well-fixed acetabular cup also? I will go back to the X-rays again. Yeah. So my next mode of controversy was, now should we go ahead? Now we have to revise the thing. So should we go for a revision of the cup and the stem, or only the stem, or only the, I mean, yeah, both the things. So next was the, this was an article by Alper, which said that how to go ahead with removal of the stem. Only the proximal, without doing any osteotomy, will we be able to remove the stem? So for cemented, it was okay. It was not good for porous coated stems. This may not work without doing any osteotomy. So next step of osteotomy was a cortical window osteotomy. And the third one was a ETO, which is extensive osteotomy. But it is well described in literature. So that was the post-op immediate X-rays which we did. We did a cortical window osteotomy from the posterior approach. A lateral window was removed and we could get away with it. So would you like to comment on this? Yeah, it is not. It is not an accident of Pentecost. Yes, sir. It is an extensive and a last option for this particular. Now that's what is the opinion of the, that is a level 6 evidence, expert opinion. Now what the literature says is this: a step-to-step approach should be considered for the extraction of a broken stem. The cortical window method can be considered a second step if proximal extraction methods fail. And ETO should be considered as the last step if at all the techniques fail. So this is what the literature says. But yeah, we do agree that ETO has been commonly practiced and it is not. No, this is one of the literature I quoted. I searched around 10 to 15 literatures, and this for this particular case also I searched. So they have ETO is the last option, and they have a reason for that, and I'll come to that. Cortical window osteotomy provides better mediolateral or anteroposterior stability than a ETO. But yeah, of course, commonly and popularly done is ETO. I do agree on that. Yes, sir. Yes, sir. Yes, sir. So the now very true. So when you open up the hip and you can remove the loosened stem from the same approach. So why do we need to have an extensive osteotomy which can be done with a osteotome and a hammer? Yes, sometimes we are fools. I agree, because yeah, if around I can, yeah, yes, yeah. So the cortical window is big enough. So it is from the lateral side. It is only to provide more stability to your fixation. I mean, that's the only advantage you can say the cortical window has. And what Manoj says is very true, but the only thing is if it has to be a loose stem there. If it is a good diaphyseal fixation and yes, sir. Yes, yes. But yeah, yeah. Yeah, I mean, how we can approach. But if this fails, cortical window fails, very true, ETO has to be the last option. Yeah, but without ETO also. No, with this also we can remove the cement. I mean, you can't find now cement in any part of this because proximal 5 centimeters we can remove without doing an ETO from the proximal, from the end which we can see the stem and the cement. And the remaining part where we can't approach, then that part has to be osteotomized. Yes, I didn't go for the. I thought it was be a more extensive surgery, so I left it. It was well fixed, so and it fortunately for me it held very well. And now the data for the cortical window. So with use of a anterior cortical window or a lateral cortical window, a well fixed stem can be easily removed and a new stem can be inserted with firm mediolateral or anteroposterior stability in the proximal femur in division TH. So that was what the authors recommended. Another paper and they have the same thing. They can be very well removed, but then that might be justified because I use this technique, so so patient did very well. He had a good range of movements, and that was the take-home message. So proximal fixation is very essential for longer durability of the stems. Distal rimming of 2 mm more will be beneficial in the long term. Poly stem is the right choice. HA coating of around 50 microns is what has been ideal, but we never asked the company guys for this. And modularity needs to be revisited. We need to have answer for this. Cortical window is a bailout technique, then exit. Thank you for your patience.
Thank you, Alok. That was a very good case. And I think there are different ways to bail a cat, right? What you mentioned, you showed a literature. So for time being, let's believe in Alok. Cortical osteotomy is a better way approach. Till Alankar comes out with a reference that ETO is better than cortical window. Till that time, we believe in you.
Sharmila ma'am has to leave early, so I would like chairpersons to felicitate Sharmila ma'am after. We'll go on to our next case.
Dr. Suhas and Dr. Sameer. Suhas, please proceed.
Good afternoon to all faculty and gathered delegates here. I'll be presenting a short case on shoulder. And I'm myself Dr. Suhas. I'm a senior resident of AIIMS Nagpur. And coming to the particular case, the whole story has started 1 year back when a 23-year-old male sustained a road traffic accident and a push injury he has sustained. And he was asymptomatic in last 2 months, and he was experiencing one more episode of dislocation which has reduced on himself, and following which event the shoulder has dislocated multiple times, including daily routine activities and sleep. And the patient has got presented with the following findings like coracoid tenderness present, and knee compression test was positive, load and shift test was positive, and anterior door shift was of grade 2 with no hyperlaxity. And routine investigations, X-ray showed coracoid fracture, CT scan showed a glenoid bone loss of 25% and a Ogawa type 2, that is avulsion fracture of the coracoid. And MRI was done to rule out the labral injuries, and there was labral was deficient anteriorly, and there was no associated rotator cuff tear. On computed tomography and 3D images, we calculated the glenoid bone loss, which was considered to be a diametric method of 25% bone loss was there, and the horizontal part of the coracoid has been sustained a fracture, and that has been used as a graft here. And the MRI images showed no rotator cuff associated injuries, and the humeral bone loss was calculated of around 9 mm, which was a Hill-Sachs lesion, which is compared to be a far less compared to the glenoid tract of 22 mm. So this was a non-engaging type of Hill-Sachs lesion. In summary, we have clinically an anterior shoulder unstable patient with 25% of moderate bone loss of the glenoid, erosive bone loss, and type 2 fracture, which is an avulsion, and the MRI has a non-engaging on-track lesion. So coming to the associated injuries with the shoulder instability, there are a lot of literature. The literature has mentioned about a lot of concomitant injuries like greater tuberosity fractures, glenoid rim, scapular fracture, and acromioclavicular injuries, and rotator cuff. But the amount of which is very less in compared to the coracoid fracture association of around 0.8 to 2%. Coming to the coracoid fracture in particular, it has got 2 types according to the Ogawa. Type 1 is a posterior to the coracoclavicular ligaments, which needs operative fixation, and there is no dilemma in this one. But a type 2 avulsion fracture, which is very anterior to the coracoclavicular ligament, can be treated conservatively, but provided the type 2 avulsion fractures, if treated conservatively, may end up with painful non-union or may prevent successful dislocations reduction also in humeral dislocations. But coracoid fracture fixation is feasible in every patient if associated with any glenoid deformity or AC joint injury or floating shoulders. So coming to the operative conflicts in our present case, the arthroscopic versus open anterior shoulder stabilization. Obviously, the patient has got a high instability severity score as his age is very less, and he has sustained a moderate glenoid erosive loss of 25%, and he has been barber by work, so occupation, so he needs his shoulder in skillful activities. So we opted an open shoulder stabilization procedure, and ramplicization is not needed as the patient has a 25% of glenoid loss that will straight away will be dictated to the lateral procedure. Coming to the measure, in summary, what we got is a patient suffering from last 1 year with a chronic instability. The recent 2 months history of recent episode would have caused him a coracoid fracture that has been made him to walk into our outpatient department. And on CT scan, we have a glenoid bone loss of 25% with a type 2 avulsion of the coracoid fracture. And on MRI, it has a Hill-Sachs lesion of on-track lesion with a glenoid tract of 22 mm with a moderate glenoid loss. So we opted for the open shoulder stabilization, and open lateral procedure using a coracoid fracture fragment with a conjoint tendon provides an excellent graft for the procedure and help in tackling the both problem in a one go. And what we did was the anterior open shoulder stabilization with a lateral procedure with a capsular repair using a suture anchor. So this is an intraoperative images. We classically approach the shoulder with the deltopectoral approach. The fractured coracoid fragment was separated from the adherent tissues, and unfortunately the coracoacromial ligament was not present with the fractured fragment. So, and the subscapularis was split between the upper two-third and lower two-third, and vertically the capsule has been opened, and the joint and the anterior inferior surface of the glenoid has been prepared for the graft recipient, and the graft was fixed with the two cannulated screws. And the post-operative imaging showing the satisfactory placement of the screws and bone anchor, and the capillary view showing the adequate length of the screws. And coming to the post-operative protocol, the patient was put on a shoulder immobilizer in a chest binder for in adducted position for 2 weeks. And after the suture removal, the patient has been put on the pendular exercises for capsular stretching, and isometric rotator motion exercise has been permitted by the pain. As permitted by the patient has been advised to do. And coming to the 6 weeks follow-up, the patient has got the right side is an operated side. The patient has a fair amount of abduction. On 3 months of follow-up, we can see the fairly incorporation of the graft. And on the successive follow-up of 4 months and 6 months, we have got a good abduction. And in the last follow-up, he has got a good, fairly normal overhead abduction. And coming to the forward elevation, the patient has progressively able to achieve the near normal overhead forward elevation. And coming to the external rotation, that was restricted in the last up to last 2 months. In the last 6 months follow-up, the patient has got a restriction of restricted by 20 degrees only, and this has been very well marked in the last in the abduction. So that suggestive of the capsular repair may be a problem. There may be a problem in getting the full external rotation in this patient. So 6 months CT scan showed a well uncompression of the graft with a well position of the CC screws. And the take home message will be the shoulder instability and coracoid fracture can be dealt in the same setting. And the coracoid fracture fragment is provided as an excellent graft material. And certain limitations like adequacy in the graft size, shape do exist. That must be that must be kept in the mind of operating surgeon. And some coracoid fracture may accommodate single screw fixation in a rarely cases also. Thank you for the opportunity, one and all. Thank you, sir.
So the idea of presenting this particular case was that in case of the recurrent shoulder dislocation, many times we decide the management depending upon only on the number of episodes which are happening. But there are certain other factors which you should take into consideration, like the age of the patient, amount of the bone loss, also the associated injuries which can be there. Coracoid fracture, these are the rare injuries which are associated with the recurrent shoulder dislocation. And in this particular case, there was an indication for a lateral procedure, and we took the advantage of that particular bone fragment to fix it with the 2 screws. There are certain reported cases in which the fragment was very small, they could get away with a single screw fixation also.
Had there been only Bankhart's lesion, no glenoid bone loss, and with coracoid fracture, so how would you
In that particular case, the maneuver would have differed. We definitely would have gone for orthoscopic Bankart repair along with the coracoid fixation if it requires management, if it is non-united. And regarding the iliac crest graft, Manoj sir asked, iliac crest grafts, yes, there is an additional graft site morbidity is there with the iliac crest. Iliac crest graft is usually reserved for the failed lateral procedure, where the lateral procedure has failed, there is the graft incorporation is not there, or there is a recurrent dislocation. In that case, iliac crest graft can be used. And the advantage, additional advantage with using a coracoid process, as the you get a sling effect, which you could not get with the only the iliac crest graft. Yes, yes, yes. Not so, sir. Not so. Yeah. So there are certain reported cases are there when you repair the capsule. There are certain say that you just leave the capsule once you are done the sling procedure, just leave it. certain indications are there where you repair the capsule to the glenoid. So additionally, we are doing the Bankart repair. So if you didn't take proper precautions while doing the Bankart repair, then it can result into restriction of the external rotation. Even in a well-done cases of lateral procedure, there would be some amount of terminal restriction of external rotation can be there.
Thank you.
Thank you. And I will just like to take this opportunity to invite to you all at All India Institute of Medical Sciences, Nagpur on 11th of December, Sunday morning for a clinical meet. All are welcome to present their clinical work. Please contact me for any interesting case presentations. Thank you.
Thank you,
Samir.
So now I invite Secretary of Vidarbha Orthopaedic Society, Dr. Neha Godghate, for Thanksgiving.
So first of all, when this idea came up, there were no questions or doubts from Dhopavkar sir. So the first person I would like to thank is President of VOS, Dr. Dhopavkar sir, for his total commitment. And sometimes I'm confused whether I am the secretary or he is, because he's still working more than me. Second, I would like to thank Convenor, Dr. Neha. Well done. Few sleepless nights for her, but she has done a good job. And this is also a unique CME that this is the first CME that is being conducted live on OrthoTV. So that is also one achievement for VOS. And I think this is the first time that someone from outside of India has also come as a faculty for a CME. So I would like to thank Sharmila Tulpule madam. Unfortunately, she is not here. Next, I would like to thank our eminent faculties, Dr. Binoti madam and Dr. Chasanal madam. They have taken flight at 5 a.m. today. I think they must have left home at around 3 o'clock in the morning. They still look fresh. And Gauri, I think it never seemed like this was your first stop. You're absolutely spot on. VOS wishes you all the best. And I think the kind of presentations that we have seen, I would like to say, means I can say 10 times excellent. It was crisp presentations and very good take-home points. So thank you so much, all the faculties, and very good case presentations by Alok sir and Samir sir. Thank you so much. And before I would like to end, I would like to thank all the delegates. Especially Apte sir was the first who came here. So a lot of senior VOS members were here on time. So thank you so much. It's all the delegates who makes this meet successful. Thank you so much. Yeah, sorry. Pankaj from Sun Pharma. Thank you so much for sponsoring this event. And yes, our AV guys, Gauri, thank you so much. This was crystal clear presentation. And some outside faculties, Gadegone sir has come all the way from Chandrapur. So thank you, sir. And we would like to give our certificates now. May I ask Dhopavkar sir, please, to come on stage.
Dr. Binoti Sheth ma'am from Mumbai. He is HOU of Orthopedic Department in Sion. Very humble person and my inspiration from KEM. Next faculty is Dr. Chasanal Rathod. He is a pediatric ortho surgeon from Mumbai. Next is our younger Gauri, Dr. Gauri Patki. And our senior VOS member, Dr. Gadegone sir. For our case presenters, Dr. Umre sir. I have it. I have all. And another case presenter, Dr. Aradhya and Dr. Samir Dwinmutta, sir. And lastly, myself. Everybody is now invited for a lunch, sumptuous lunch.